Make sure you sign in, please. I'll leave it up for a little bit. Need 2 more people to sign in that I see here. I got 9 out of 11. Whoever didn't sign in, make sure you sign in, please.
I'm on it twice.
Isaiah, you're twice?
Yeah.
Okay, so then there's only 1 more person then. Anyone else on twice? Different devices? So just 1 more person. Okay, let's begin. Let me record this. Recording to the cloud
in
now as I
progress.
speak. Good evening, everyone. Frank Nookie here, one of the senior instructors, CICs from LaGuardia Community College. We are going to be reviewing for the next exam, I think is exam 9. I think it covers respiratory, neurological, anaphylaxis, and general pharmacology. Okay, we're going to start with general pharmacology. You know how it always starts: national EMS educational standards, competencies. We'll talk about the kinds of medication you use during an emergency. There's like 7 medications that you carry on the ambulance, according to New York State. Remember that this book is national, so you may see certain things that nationally they carry in other states and we don't in New York State, but we cover basically all the ones that New York State carries. We'll definitely talk about self-administered medication, peer-administered medication, and assist administration medication to that patient. That one of those words, when they say assist administration medication, especially the ones the patient may carry that we assist with them. Okay, think of nitroglycerin. We do not carry that on the ambulance. MDI, metered dose inhaler. We do not carry that on the ambulance. Okay, activated charcoal. We don't carry that no more. Okay, but you need to know that according to New York State and of course nationally, according to the book. Here, always test questions. Please make sure in your book you know names, and you need to know the generic and also the brand or trade name. We're going to go over that, especially the ones they love to give you on exams. There's a nice chart in your textbook that breaks it all down of all the medications you should know. Know the effects, especially when we come to side effects on that. You need to know that, so highlight that in your book. The actions, and especially the 2 last ones. Indications and the contraindication, okay? Why is this medication given and why you would never give it? Contraindications. There's 2 ones called absolute and relative contraindications, and we'll go through those meanings also. So I'm going to tell you to make sure you highlight that. Then you got complications, routes of administration of that medication, side effects, interactions, the doses of the medications administered. You're going to need to know like nitroglycerin, how much oxygen you're given, depending on the device, aspirin, you know, how many aspirin according to New York State and how many milligrams, the epi auto injector. Always test questions. You have to know that. I'm going to give you dosages, and you need to know what they do exactly, because they love to ask you test questions on that. Know this word, always test questions right here. Pharmacology. It's the science of drugs and medication. It's interchangeable as medication with drugs. Okay, you need to know both of those words. Substance used to treat or prevent disease or relieve pain. And then the word in the bottom, pharmacodynamics, process by which medication works on the body. Know all these 3, highlight in your book. I guarantee questions probably going to come with this one. They always ask that one. What's pharmacology, okay? So make sure you know that. They may not ask this or this one. Just make sure you know it. Highlight that in your book. This, the 4, you need to know. But this easiest way to remember these 4, especially the first 2, you see the one, agonist, that top one, medication that causes stimulation of receptors, and then the antagonist. I want you to think of 2 drugs. I want you to think of heroin, which is opiate or opioid. It's a CNS depressant. It brings everything down. So if you think of that as your agonist, I want you to think of your antagonist, Narcan, naloxone. It counteracts that. Get that? So make sure you know that, because they may ask you that. So if a person's overdosing on some kind of, let's say, CNS depressant, opiate or opioid, which could be heroin or methadone, let's say, you are going to give the antagonist to counteract that, which is going to be Narcan or naloxone. Okay, so that's the easiest way to know those 2 words to keep it separate. So you notice that the antagonist, the Narcan, it like blocks it. It blocks those receptors, continue doing the effects that the heroin or the methadone was doing. That's the easiest way to remember those. Know the word dose, the amount of medication that is given, and which depends on the patient's weight, their age, how much they took, and so forth. And then the word action, the therapeutic effect that medication is expected to have on the body. That's what you need to know here. So highlight that in your book. Make sure you know those. You can highlight these. They may ask you on one of these, the onset of action, duration, elimination, and peak. You can highlight that. If you want a meeting, if you don't, then highlight on your book or you writing this down. The onset of action, time for medication administered until clinical effects occur. Duration, the length of time that clinical effects persist. Elimination, how medication or chemicals are removed from the body. And then the word peak, the point or period when the maximum clinical effect is achieved. Go to your book, highlight it. I don't have the textbook in front of me, but if you do that, feel free, okay? I'm going to give you what for sure I know I see always on the exams, especially. Factors of medication, how it works, the route. You need to know every route, okay? We're going to go over every one. I'm going to tell you which ones I always see on exams and give you examples, okay? Make sure you know that. Shock states, depending how bad, what's going on with the patient, can they go into shock? And you need to know what you're going to do to help that form of shock. This word you must know, contraindications. You know the word indication, that reason, condition. They love to give this on exams right here. Indication, know that, and know that contraindication. Indication, the reason or conditions where that particular medication is given. You must know that. That contraindication, situation in which the medication would either harm the patient or have no positive effect. And then they give you these 2 words separate. Make sure you know those 2. That absolute contraindication, situation where the medication should never be given if the contraindication is present. And then the relative one that you see there, that contraindication, situation where the benefits of administration of drug may or outweigh the risk. And then the word adverse effects. What I see always is the side effects, but know these 2 in case they ask you. The adverse effects means any action of medication other than the desired ones. And then you see those 2 underneath, unintended effects and untoward effects. Directly from your book, unintended effects, effects that are undesirable but pose little risk to the patient. And then untoward effects, effects that can be harmful to the patient. Make sure you know that and highlight this in your textbook. This always test questions. You must know generic and trade name. So you see the word ibuprofen there. That is small, lowercase letter. You notice that. Ibuprofen, that's the generic. If you wanted the trade or brand name for that one, you would think of Motrin, Nuprin, okay? This is another one, Advil. Those 3 are trade or brand names to that generic. Same amount of milligrams when you look at the back of those boxes. Me, I'm a generic person. Cheaper, does the same effect, I'm buying that one, okay? $2 $2 paid to 10. Yes, Isaiah.
Are you saying that our generic Name's gonna be lowercase.
Yes, you'll see this one here.
You'll see this one here.
Yeah.
Mostly they're lowercase, but a lot of your trade or brand names are going to be capitalized. The first letter is going to be capitalized. So when you see a test question on ibuprofen, you're going to see it say Advil, okay? Nuprin, okay? Those are capital letters. Those are trade or brand names that you see in the pharmacy. If you flip it over, you'll see the ingredients. You'll see it say ibuprofen, which is the same thing, but that's the generic. Do you understand that? Beautiful. So like Tylenol, that's a trade or brand name, right? You know Tylenol, everybody buys Tylenol, right? But did you know that when you turn it over and you look at it, it's called acetaminophen? Acetaminophen is the generic. So like I said, if Tylenol costs me $2 in Walmart, excuse me, the generic of Tylenol, which is acetaminophen, costs me $2. I'm not going to pay $10 for the Tylenol just because it says Tylenol. It's just me. You following me? So you need to know what's the difference. They're going to ask you that. They're definitely going to ask you over-the-counter medications, okay? You can look at each of these meds, but if I was to give you a test question, it would be over-the-counter medications. What's the difference between that and, let's say, a prescribed medication? Prescribed is exactly that. It is prescribed by the doctor to the pharmacist that you cannot buy over the counter. Okay? So you need to know OTC in case they ask you test questions on that. Recreational drugs, you know it, marijuana and all that other drugs that are out there that's recreational, illegal, cocaine, heroin, and so forth. You need to know that just in case they ask you. They may give you these two words. You can highlight that in your book. You have the internal medication into the body to the digestive system. And then the parenteral is the one that goes, into the body to some other means. So know these two words just in case, highlight it in your book. These you must know. We are going to go over every one. Can anyone here give me a medication that is given rectally?
That would be Epi.
I don't want you to think of Epi right now. Okay, a form of diazepam, which is Valium, medics give that, yes. But I want you to think patients take, not what maybe advanced EMTs or paramedics.
What the seizure medication?
No, rectal. I want you to think rectal medication.
Suppositories?
There you go. Suppositories. What else? Enemas, suppositories. Yes, diazepam is a medication, which is Valium that could be given rectally, but mostly medics give that, okay? Rarely do you see patients take it, but yes, they may have it. I want you to think rectally, okay? So just know that in case they think and say something to do with rectal. How about oral? Give me a medication people take orally.
Nitroglycerin?
Yes, but mostly nitroglycerin is given what way? Don't think.
Oh, sublingually.
Sublingually. That's
Yes.
what you need to know.
Right.
Sublingual underneath the tongue. Excellent, Louis. Sublingually. Excellent, Deb. Okay, you need to know that because they'll give you a test question. Most of these EMTs give this medication underneath the tongue. You know it's sublingual, nitroglycerin.
Right.
Right?
So Tylenol, I guess, orally.
That's right. Tylenol, you think of orally. They're going to take you any tablets, capsules, and so forth. Excellent. Sophie put oral glucose. Excellent. It's true. Oral glucose goes orally, but towards the buccal area, inside the mouth on the side. Okay, inside the mouth, the cheek area, not the front, but inside, called buccal. Buccal. You need to know that. They'll probably throw questions like that at you to see if you're confused when they're giving you this medication, whatever it may be. Stick with oral glucose on that, okay? Because mostly you're going towards what? The buccal area, which you have your mucous membranes, okay? So make sure you know that and understand that. So we got those two. Let's get another one. Okay, IV. What kind of medication people take IV? And they don't have to be medication normal or how can I say not legally, it could be illegally. What they take illegally?
Morphine.
Morphine. What else?
Fluids, like
Are
saline.
they possible? Fluid.
Fluids. Yeah.
Someone just said something else. How about that illegal drug out there? Heroin. Yeah. Heroin is known for that, right? Pain medication is possible. That is true, right? So you think, test question right here all the time. You better know this one. Which way is the fastest? Right here. If for some reason you didn't see this into the vein, then it would be interosseous, into the bone, called the IO. But mostly I see this on exams. I see this one on exams also called beneath the skin, subcutaneous, PPD. Think of PPD, right? PPD is that medication that they use and they put it the sub C, right? And they circle it with a pen or something like that and say, see me in 48 to 72 hours to see if it's very red or is it swollen. And that is to see if you've been exposed to tuberculosis. So remember that. They ask you a question to do with this. Think of the PPD. Kenny, when you get a chance, Google PPD meaning and put it on the chat for Nuki, please. Because I know you're pretty fast, a lot of you with the computers. And I want them to know exactly what it means. I think it is protein. Thank you. Appreciate it. And put it on the chat for me here. I appreciate it. There you go. Purified protein derivative. That's the one. Now, IM, you must know this. Which one we're always given IM as EMTs or medics?
Is it epi?
Epinephrine. The epi auto injector. You better know this about the epi. Always exams. Test questions. The dosage. The dosage for the adult, 0.3 milligrams, 0.15 for the pediatric. Must know that. You must know how do you give it. You give it on lateral thigh, mid-lateral thigh. Now I'm hearing, and quote me again, especially the night class, okay, and the day class. According to the book, you're supposed to hold it there for 3 minutes and then rub it for 10 seconds. This is what I'm hearing. Yes. Please. I was told.
The auto injector or
the epi auto injector was for 3 minutes.
it's 10 seconds.
10 seconds you rub it.
No, they say you inject it for you let it stay for 10 seconds, then you can release it.
Okay, I'm hearing two different things. Okay, second one. Maybe I'm saying the second wrong. Excuse me. 3 seconds and then 10 seconds to rub. Kenny or one of you double check the book. I know the book mentions 3 and 10 on the pharmacology because I want to prepare you, make sure you know this. Because I always have rubbing it, calling to New York State for the 10 seconds and holding it. So I want to make sure we're getting this correct because we were given 2 different ones. So definitely need to know the IM. Let me see if I can find it also because we have to know that. Do me a favor, if it's not there on the pharmacology, go to chapter 21 under the epi auto injector. Kenny, see if you see it there for anaphylactic shock. Lewis, it says hold for
Under
7 seconds.
pharmacology, it just says hold firmly in the thigh for several seconds. Immediately place the unit in an appropriate sharps container. So under pharmacology, it doesn't say exactly how long to hold it, but you said where else?
Chapter 21. The reason why I want to clarify this because there was a discussion with that, especially during the night class review on Friday, and then there was discussion with that with myself and the director. Coming directly
Yeah.
from Christine.
I'm under the impression that it was 10 seconds myself.
And that's what I was before.
Can inject it. You don't have to actually hold it. You just do the rubber tug type stuff. That's it.
Yeah.
So, Kenny, are you saying, and Kenny and Isaiah, are you saying hold it for a few seconds, and then rub it for 10?
Yes. According to the protocol, it's actually says 10 seconds, but that's about it. That's the only one that says 10 seconds.
For the audio ejector, but first the released one. What was the other one? The check and inject. Actually, I don't know anything about that one, but I know with the auto ejector, he said 10 seconds. It was adamant about 10 seconds. You can do no less than 10 seconds. No less than 10 seconds, they say specifically.
Okay. I would double check it also on the notes that they send me to make sure, because I know for sure, most likely they'll give you test questions on the epi auto injector when the dosage and so forth and how and where. Okay. So I will clarify that again also during the break. But you said in protocol, it did say 10 seconds, Kenny? Okay. And that was to rub it, correct? Or just hold it for 10 seconds? Okay, but it just says hold it there for 10 seconds? Okay, thank you.
Yep, that's what I'm getting here. It says place the tip or auto injector against lateral part of the thigh. Hold it in place. All medication has been injected 3 seconds, and then rub the area for 10 seconds.
What chapter is that? Where's that at?
Chapter 21, page 815. It shows the skills drill 21-1 using an EpiPen auto injector.
So it says 3 seconds to inject.
It says hold it for 3 seconds and then rub for 10 seconds.
Okay, then look out for the words, people. Okay, what is that you just put there, Kenny? Chapter 21? Okay, thank you. So the people from the night class, there you go also, just in case. So you know, because we went over this review on Friday and remember what we spoke about. And then I was clarifying this with the director. Okay, that's why I'm trying to make sure with you all, because the way I was hearing it from Isaiah and some of you, that it's possible they were telling you that 10 seconds, hold or rub. Now you know here exactly. Okay, so when you see the words on a test question, you know the difference between holding it and rubbing it, just in case. All right.
But usually the auto ejector, you do it through clothes usually. So how will you rub it?
After the medication goes in.
Yeah.
Then you take the and then you disregard it and you put it in the shop. And then you're supposed to rub it.
Even like with like clothes over it, like they have like jeans on. You just rub the area.
You're gonna do without the jeans on. You can use it and it will go over to the jeans. But if you let the jeans on and you inject it, you can still rub it for those 10 seconds. But I recommend skin to that epi injector. You know? But if you have no choice because it's life-threatening, they're unconscious, unresponsive, boom, on the side of the thigh, you got to do what you got to do. You know, you understand what I'm saying? That's different. But according to textbook and protocol, make sure you follow that. Give me inhalation medication to the lungs. What's the number one drug we inhale? Besides that?
Oxygen.
Oxygen, Kenny. The number one drug. That's a drug too, oxygen. You forget that's the drug. Alburyl sulfate via nebulizer treatment. You better know that. And you better know it via the MDI, meter dose inhaler. I will give you a test question, MDI. We don't carry it. The patient carries. What's another name for the MDI? Well, we know it's meter dose inhaler, and it gives a preset amount. We know that. All the time, they squeeze it. The questions are now, that device that you're looking at, that MDI, has two names. If you're using the trade or brand name, you're looking for Provento or Ventolin. If you're looking for generic, it's albuterol sulfate. No, all three. Trade or brand name, Ventolin or Provento. Generic, albuterol sulfate. You understand that? What type of patients we use albuterol sulfate for? Asthmatics. Okay? Make sure if you don't say, I could read your lips, Kenny. If not, put it directly on the thing here. Asthmatic, asthma. Thank you, Noreen. Right, you need to know this. Sublingual, I think Dad went over this. We said sublingual, nitroglycerin. You need to know how many milligrams, 0.4 milligrams, right? One tablet each. You could give up to 3 every 5 minutes. The blood pressure must be more than 120 systolic. Do not go by the book that says 100. 120 systolic according to New York State. Be very careful. What is the main job of that nitroglycerin? Okay, it's to dilate the blood vessels and especially the coronary arteries. Is it going to lower everything? Yes. Okay, especially that blood pressure. So be careful. Can you harm a patient if their blood pressure is already low and you give them nitro? Yes. Can you harm a patient if they're taking some kind of enhanced drug for erectile dysfunction, like Viagra, Cialis, and Levitra? Yes. Okay. Remember the hours. Now, I'm hearing 2 or 3 numbers, 24 to 72 or 48 to 72. What hours will you talk? That you got to be careful if that person up to 72 hours, Kenny? Is that agreeable? Louis, Debbie, Isaiah, everyone, Nick, Sophie, everybody here? Is it up to 72?
Up to 72? You actually, if you, the last time you took like erectile dysfunction, erectile pills? Yes. Oh, okay, yes. I don't remember. But yeah.
A lot of people are saying up to 72. So if you see that on an exam, make sure you know that. Now, transdermal. Give me transdermal drugs through the skin. Those are transdermal. Those are patches. Okay? Nicotine patch. Give me another patch.
Nitroglycerin patch?
Nitroglycerin patch.
I'm going to stick with the nitroglycerin.
You give him fentanyl. You're trying to kill this guy. Birth control. Awesome. Birth control patch. Morphine patch. According to Kenny, he's getting the good stuff. Fentanyl patch. Yeah, he's getting the one he want to kill people and things like that for sure, right?
I'm sticking with the nitroglycerin.
Nicotine, me too. I'm sticking with nitro and maybe the birth control and nicotine, right? And maybe the morphine. I don't know about that fentanyl. Maybe Kenny can hook us all up and get fentanyl patches. I don't know, but understand. But you know where I'm going with this. Intranasal, what is that? That MAD device. What type of medication is it? It's for opiate overdose. The MAD device. Naloxone, Narcan, right here. This one, you need to know this word, M-A-D, MAD device. So make sure you understand that. Intranasal, how many milligrams in each nostril? 1 milligram each, total of 2, 1 each, right? Beautiful. So make sure you know that in your book. This is a nice chart in your book. I will look at that. I'm telling you right now, the ones I always see them given on exams, sublingual, by mouth, IV, inhalation, intranasal, intermuscular, subcutaneous, transcutaneous. Know them, okay? If you can remember all these, awesome. But remember, sublingual, underneath the tongue. By mouth, you name this. Remember, once they take it by mouth, it's going to go through the digestive system. So it's going to take a while, okay? This, immediate, fastest. Always a test question. Inhalation, intranasal, IM, and subcutaneous. Any questions on any of these routes of medication?
I have a question.
Okay.
So are you saying that because it go under the tongue, it's not by the mouth?
It's by the mouth, but they're not swallowing. So I want you to go sublingual underneath the tongue, nitroglycerin, because you're going to get it confused, because when you give this to a patient or assist in the administration of this drug, you're going to tell them, please do not swallow this. You want it to go underneath the tongue. So technically, is it in the mouth? The answer is yes, Isaiah, but they're not swallowing this. When I mean PO, I mean they're going to swallow this. They're going to get it and going to swallow. They're going to, like aspirin, you do it by mouth, right? 324 milligrams, according to New York State, 81 tablets each, 81 each, 4 times 81 is 324. That they have to actually chew. It goes to the digestive system. You follow me? Nitroglycerin goes underneath the tongue into the mucous membranes. See the difference? So that's the test question that we always give you. So separate those two, please. Say that again. Yes. Yes, it is. Oh, these two? Okay, I see where you're going. So you're going subcutaneous, transcutaneous, and mouth up here, which is all three slow. I'm telling you right now, they're not gonna do that to you. Okay, I don't want you to think that. No, Louis, I see that face. Louis, take it for Nuki. Okay. Do I mostly know and used to write a lot of these exams in the past when I was there physically? The answer is yes. But no, we won't do that to you. Nor with the state. The state is a very easy exam. Okay. I already send you all a lot of good information to study for your state written. That's what all those handouts that I put on your WhatsApp for the day class and the night class, the 80-page one, the 37-page one, the protocols, the 118-page one, and then I send you a new one from, I think was Northwell, I think it is. I send you, it's like, I forgot the pages. Those are all to prepare you for the state written. You go through all that in your protocols, you're going to kick butt on the state written. It's getting to the state written. That's the problem.
Where can we find those?
I put those, Nick, on your WhatsApp.
What's that word? All right, thank you.
Yeah, you're welcome. Look on your WhatsApp. Kenny, is there any way to put those pages or resend it? I can resend it, Nick, with no problem. You should have a total of 5 handouts. That's including the protocol.
I'll hit you up if I don't find them, but I'll probably find
Okay,
them.
if not, I could. Which group? The WhatsApp? Okay. Okay, no problem. Thank you. You got that, Nick?
Yeah, thank you.
You're welcome. Okay. These are all the different forms. If they ask you tablets, capsules, just read up on that again. You know the tablets. Think of aspirin and so forth. Solutions, if they ask you, suspensions, if they ask you, highlight that. This they always ask you. See that meter dose inhaler? You see what it says, delivers the same amount each time? It has a preset amount. You must know that. Preset amount, always. I take this medication as needed. So I need it, tell them to hold my breath as long as I can, or I tell the patient to do that, then I take another puff. So the average is 2 puffs every time you have this problem to do with asthma and so forth. So know this one, MDI. Know the generic name and the trade or brand name. You can know those topical medications, ointments, creams, and lotions. Highlight that in your book. Transcutaneous medications to the skin, we already went all that, also referred to as transdermal. This one, you know how many grams is this little tube right here? If any one of you ever had Arizona iced tea, that nice long one, that's the same amount of sugar in there. 37.5 grams right here. This little tube of nice glucose, nice sugar. You need to know this for diabetics. What type of diabetic? Type 1 or type 2? Most likely a person in type 1. Could it be type 2 also if they're hypoglycemic? Yes. So what you look for, don't let them confuse you with type 1 or type 2. Look for diabetes mellitus if the person is hypoglycemic, low blood sugar. What is the norm BGL? 80 to 120. Lower than that, especially going down 50 or lower, they're going into a form of what we call insulin shock also. They better be getting that sugar. In order for you to, yes. That little tube right here. Yes. That's like, yeah. And I'm telling you right now, this one here, depending on the manufacturer, I used to see this 37.5 grams on this one. Now, can you give half of this? Yeah. Would it add up to what you give it to the patient on a tongue depressor and put it to the side of the mouth on the buccal area? Yes. Can you give the whole thing to the hypoglycemic? Listen, is it going to kill them? No. Is it going to increase their sugar? Yes. Is that what you wanted? Sure. I would not give it to a patient who's hyperglycemic, especially if I notice the signs and symptoms of the sugar being too elevated. When you see the sugar hyperglycemic, what do you see? You have Kussmaul's respirations, deep and rapid breathing. They have that smell or that odor on their breath, acetone or fruity. You follow me? The skin is very dry. I'm not going to give it to them because the sugar is very elevated. Under 80, someone put here, 50 or lower is considered insulin shock. Okay? Anything under 80, 60, they're still hypoglycemic. Okay? Could you give it to them if they're a little AMS? Of course. But I know me, being a type 2 diabetic, when my sugar is like even 62, I get the jitters and the shakes and everything. And then sometimes I feel like I'm almost forgetting, but I know my sugar's low and I'm at that number. I wake up in the middle of the night to use the men's room and then I check my sugar and it's 60 or 62. I say, oh, I got to get some orange juice or something, right? So be careful when they ask you the numbers. You know the gases already, oxygen. You know the nasal cannula, non-rebreather. 6 rights, you must know this. I always write this. They're going to ask you the 6 rice and ice. Always going to be a test question.
What does ICE stand for again?
I know they're 9, but what's what I do? That's going to cover. They include the education, Kenny, right? They include, they have the right to refuse, education, response, and all that. That's good and dandy. I'm telling you right now, when it comes to your test questions, know the 6 rights. And if you know Dr. DPTD and ICE, watch this. Dr. DPTD, is this the right drug, the right route, the right dose, the right patient, the right time, documentation? Dr. DPTD, 6 rights. ICE, not in case of emergency, integrity, clarity, expiration date. You know that, you'll cover any test question they give you, okay? So what we like to give you is probably all this you look for when you're looking at a medication. And yes, Kenny is right. There's like 9 now. He's 100% correct, okay? The thing is here, I give you a mnemonic to help you that you'll never forget this. So they're going to ask you, you know, is it clear, the clarity? Is it damaged or broken? That's an integrity. Does it have an expiration date? Yes. Or Dr. DPTD, is this the right drug, the right route, the right dose, the right time, the right patient? Documentation. You do this, you'll never forget it. This will answer a lot of your test questions. Nick, did that help you on the ICE?
Yes, for sure.
Beautiful.
Would you recommend us learning Because in the book it's the nine rights now, so they added 3. Should we learn the 9 or the 6?
No. You should learn the 9.
Okay.
I'm telling this right now. You can know the 9. They may ask you test questions to do with the 9, but all my years, when they added these in the last few years, I have yet to see it.
Yeah.
It always goes back to those 6 rights.
Okay.
You follow me, Nick? But
Yeah.
it is not wrong for you to know that that response, that refusal, the education. I think that's included there, Kenny. Am I correct, Ken? Oh. I said that the one that Nick was talking about, to know all 9, I think the other ones were like the route, education, response, refusal, and things like that. Can I say that's correct, Nick?
Education, right education, right to refuse, and then right response and evaluation. Is that it?
There you go. Yeah, you can. But I've seen all test questions. Normally, when I will write them or see them on the state, it's a 6 rights and ICE.
Word. Thank you.
You're welcome. There it goes here. This is the one you're talking about, right? Here it goes. So we did the patient, we did the medication, they added indication, we did the dose, the route, the time. We just spoke about that you could make your mnemonic and put education in, refuse, and response. That's up to you. We did documentation. It's directly in your book, each one, I think, separately, and the meanings of them. It is okay to look at them and do it that way. It's up to you. Now you're going to get the ones here to do with the peer. And that one's just with you administer your partner or yourself. Okay? Think of toxic agent like nerve gas or what's the other one? Organic phosphates, pesticides, and things like that. Those are test questions that they would tell you to use the Mark 1 kit, and that's when you get the toxicology. Okay? Think of the other one to do with the patient. You assist the patient with administration of his or own medication. Okay, that's this one right here. And then the EMT administration directly. Okay, ones that you are authorized to give. Think of everything you give right now on the protocol, New York State. Do you give oxygen? Do you give glucose? Do you give aspirin? Do you give the epi auto injector? Do you give naloxone? Yes, all these medications you give, right? Do you give, according to protocol, albuterol sulfate, or the other one they have in there too, ipratropium? That's total of 7 different medications you're allowed to give to the patient under standing orders, under protocols. Make sure you know that, in case they ask you that. And then they got the oral medications. We spoke about that before. Aspirin, how many milligrams you must give?
324.
324, which is how many tablets?
81 milligrams.
81, that's right, right? All one shot. Boom, here, chew it. Now, test question would be, what's the first drug of choice you give in cardiac related? Oxygen. What's the second drug of choice that you must give? Aspirin at 324 milligrams. What is the third drug of choice you assist with administration of? It's in protocol. Nitro. You must know the dose of aspirin, 324 milligrams, 481 milligrams each. What does the aspirin do? You must know this. Always a test question. Is a platelet aggregator. You must know that word. Exact words. Platelet aggregator. It doesn't let it clump or stick together. Okay? The nitroglycerin, you must know, this you assist in administration of. Okay? 0.4 milligrams, 1 tablet. Or you can use a spray, right? Sublingually, you give this medication to the patient. You could give up to 3 doses of the nitroglycerin every 5 minutes. Their blood pressure must be 120 or more systolic. Make sure you know that. They love to give you that on test questions. You know the oral glucose for diabetes, hypoglycemia. I told you they must be able to drink and swallow on their own. Besides, the oral tube, the glucose, what way you could give sugar to them? You could give them sugar. What other way? I like that. No, according to protocol, you are too funny. Louis right on food, but give me something.
Milk,
Not milk.
orange juice.
Orange juice. Any type of fruit juice. Yes. Okay. Orange juice, apple juice, grape juice, pineapple juice, you name it. How about soda?
Arizona tea.
Arizona iced tea. How about soda?
Non-diet soda.
Non-diet. And they state and say in protocol, they must be able to drink and swallow on their own. If they're semi-conscious or unconscious, unresponsive, no sugar, no glucose, only oxygen transport. Okay, make sure you know that. Okay, ask when we spoke about, here goes a test question right here. Yes, it's a pain and relieves fever and inflammation. Yes, on all that, okay? But the main thing you need to know that is right here. That is your test question right here, okay? Some of you say, isn't that a blood thinner also, Nuki? The answer is yes, but I don't want you to think of it like that right now. I want you to go with what I just told you. That will help you a lot on your test questions. A lot of people do not have allergic reactions to aspirin. They have what we call hypersensitivity, okay? When we get to allergic reactions, you know what I'm talking about, okay? There goes your nitro. There goes your test questions. We know about blood pressures, 120 or better. We spoke about erectile dysfunction medication. Know all the side effects. The side effects are going to be this for nitroglycerin. Sir, ma'am, I'm going to place this with you underneath your tongue. You're going to let it dissolve. Please do not swallow this. I want you to be prepared for these side effects. You're going to feel numbness, tingling, and a burning sensation underneath your tongue. You're going to probably have a headache. You're going to feel lightheaded, maybe a little dizzy, okay? These are all side effects of this medication. I don't want you to panic, please. Let them know this, all side effects, besides what you see here. There goes your burning or tingling.
Oh, Nuki.
Yes,
Sorry to interrupt for the
you're not
inhale.
interrupting.
The MDI. Is there codeine in that will make the heart rate increase?
Not that I know of. Can they be different kinds of medications and MDIs? The answer is yes. But I know for your test questions and the state and so forth, it's a bronchial dilator. And if I remember, I think they always ask that question. I think it's a beta-2 agonist. If I remember correctly. I don't remember about codeine in there, John.
Okay. Thanks, Nuki.
You're welcome. You know, every 5 minutes, we talked about monitoring vital signs, wearing gloves, follow protocol. Epi, must know. Give me the dose of Epi, adult. 0.3 milligrams, right? Beautiful. What is the main function? What it does? Main job.
No, bronchial dilator and vasoconstrictor.
Vasoconstrictor and bronchial dilator. Everybody always get
There we
that
go.
confused. Make sure you know this for exams, okay? You need to know that. So you think of that sympathetic nervous system. It mimics that fight and flight. You notice everything's increased in the fight and flight, right? So we could say in test questions, all the following conditions occur with the use of epi except. All right? That's how they'll give you test questions. So if you know all the effects of what the epinephrine does to the body, you're okay. If you're not sure, you got to think, will it lower my blood pressure? No, it will increase my blood pressure, increase my pulse rate, increase my respirations. That's what you need to know, okay? We already went over this. True anaphylactic shock. You know that's one of the chapters we're going to go over. It's going to be easy. Don't freak out. Okay, they will ask you test questions on that chapter that coincides with pharmacology, the epi here. Okay, remember, there could be different things that will you have an allergic reaction to: foods, medications, plants, dander, whatever it is. Okay, so you may see a test question. All the following is possible patient to have allergic reaction to. And then you probably put all the above if you remember almost everything, right? But then they'll ask you, your immune system, when you get some kind of allergen that comes in, let loose these two chemicals to help fight that invader, let's say, okay? That so-called antigen, okay? It comes in there, they send out two things, the body. These two chemicals, you must know them: histamines and leukotrienes. Okay, histamines and leukotrienes. Your immune system sends out, then the body does, it responds, it needs help. So what it needs? An antihistamine, which is what? Your epi auto-injector. You following me? You have to make sure, because your body produces that also. Naloxone, you know that medication, or Narcan, opiate overdose. Opiate or opioid overdose, whatever, CNS depressant, central nervous system depressant. What that means, it brings everything down. Blood pressure, pulse rate, respirations, and so forth. They need naloxone or Narcan, 1 milligram in each nostril. And there goes the MAD device. That's how the MAD device looks. Make sure you know that. That's that mucosa atomizer device right here. In case they ask you that. Each nostril, 1 milligram each. Any questions so far?
Naloxone, that's a generic thing?
Naloxone should be the generic and Narcan, the rhino trade. Sometimes I get confused. Should be in the book. I'll look at it. I don't have the book in front of me, but I'll find the page for you. Let me make sure for you. Hold on. Naloxone is your generic and Narcan is your trade. Got it? It's on the chat. I don't know the page, but look for this, Isaiah. Medications EMTs administer or may assist administration. It's a nice big chart that has all the medications you need to know. It takes up 2 pages.
Okay? I know what you're talking about. It's a lot. Yeah, I remember.
Yeah, make sure you know that. You'll see it says generic / and then the trade name or brand name. Thank you, Louis. 508 and 509. Louis, you're the man. I don't care what they say bad about you. You like that one, right, Kenny? Like they say bad about Nuki. Yeah, he's crazy. He's CPR. What's that? Crazy Puerto Rican.
Sorry, I spaced it. What was that 508, 509 for?
508 and 509, Nick, is the big chart that has all the generic and trade names that you need to know of the medications.
Oh, word. Okay. Thank you.
Very important. You may see test questions on this.
Word.
That's why you're welcome. So we got that. We got oxygen. MDIs we spoke about. This is your nebulizer. That's that small volume nebulizer. So awesome. Okay. The albuterol sulfate or the ipratropium goes in this canister. Okay. The oxygen is connected. Right. And then they put this around their lips. They breathe in and out. Once they inhale, you tell them to hold their breath as long as they can. So they go, and they may cough it out. Let them cough. That's a good sign. When I hear my patient coughing, once they inhale and then they cough right out, that's an excellent sign because I know the lungs are expanding. Their bronchioles are opening up. That's a spacer. In case they ask you, the spacer fits over mostly the inhalers. The sleeve there has an opening, right? The patient maybe prescribe this. They use this a lot, especially in children, okay? Because when the mist goes in, when they breathe in and out, and that mouthpiece, that mist is completely inhaled. Okay, it's not like they do this. You notice anybody who's asthmatic or use it, they do this, they shake it, and then they go like this. That's what they do. They're not even doing it correctly. They're supposed to shake it, yes, then put their lips right over it, squeeze at the same time, take a deep breath in. Then hold it as long as they can. Not this, with their mouth open. Now, the spacer helps a lot for patients like that and children especially. There goes your small nebulizer, which we spoke about. Can be used while CPAP also. I've seen that done. I have done it in Jersey before, okay? So they may give you a test question on CPAP. What is CPAP used for? Patients with acute pulmonary edema, CHF, and so forth, okay? What does CPAP do? Continuous positive airway pressure. It forces anything that's in its way straight down to the alveoli to keep it open, to make sure it has good exchange of the oxygen there and the carbon dioxide, okay? Good elasticity, good contractions. So I sleep with a CPAP machine. Best thing I ever did was a CPAP because I used to stop breathing about 20 something to almost 30 times a night, okay? Could die that way, okay? CPAP, used to snore a lot in every CPAP, no snoring, just forces that air in, and I sleep like a baby. I'm out. The only bad thing, if something's happening around me, I'm not going to hear it because I'm out like a rock. So notice CPAP. What happened? My wife says she'll get me up. She's too funny. Now, better not let me die there, woman. Yeah, Darth Vader. I'll sound like that, Darth Vader. Kenny, I am your father. Oh, you are too funny, guys. Okay, you know your patient medications. Okay, questions now. You can ask me any questions. Remember, we're going to go at the end, make sure we touch base on everything, but the things I told you to highlight and make sure you know, you better know. Okay? A lot of, so far, pharmacology, you know, most likely they're going to give this. I get three or more. And is right. Isaiah, you got a question?
Yeah, I have a question. You said for nitroglycerin, they blood pressure have to be above 120, right? What about aspirin?
No. Aspirin, you want to, don't worry about the blood pressure.
Okay.
Okay? Nitroglycerin is because if you don't, you could bottom out the patient. The book states 100. That is National Registry. Don't go by that. New York State Protocol, 120 systolic or higher. Okay, beautiful.
And there's what about treatment for hyperglycemic? I didn't see anything about that.
Hypoglycemic patient. All you need to know is to be both. Okay. The signs and symptoms. How you're going to give it. There's no dosage. Got that? Beautiful. Dosage you should know is albutyl sulfate. Solution 2.5 milligrams. Okay, in case they ask you that. That's New York State also. Aspirin, ASA, 324 milligrams, or 81 tablets each, one shot. Then, of course, your nitro, which is 0.4 milligrams, up to 3 times. Remember what you have to look out for. And we went over that, and it's probably going to ask you a question here about that also. Okay, we already went over that one. Okay, number 2. Getting a bunch of C's, which is the following statement regarding medication is false. Over-the-counter drugs must be prescribed by a physician, which is true. No, it's over-the-counter, which is good. Over-the-counter OTC drugs, such as aspirin, Tylenol, and Motrin, do not require physician prescription. They can be purchased at a supermarket or drugstore. Most medications have a generic name and trade name. For example, acetaminophen, Isaiah, remember this one, acetaminophen? You know that as the generic name for Tylenol, which is the trade or brand name. And ibuprofen is the generic name for Motrin or Advil, right? Or Nuprin, I think it is. Naproxen is totally different. I think naproxen is Aleve. Okay, number 3.
We haven't found him.
Okay, so we come back.
Downstairs inside a ShopRite bag.
Okay,
Going back to the big one is Gamet's.
okay.
The other one is yours.
Thank you, my love.
It has the little foil on it.
Which of the following routes of medication administration has the fastest? You know this is going to be a test question. Intravenous. Okay, a lot of you put B. Because its administration is directly into a vein, a drug given intravenously enters the body quickly. The intravenous route is the fastest acting of all routes of medication administration. Number 4. When administered a patient a metered dose inhaler will, and a lot of you put A, deliver the same dose each time it is administered. Sometimes they use the word preset amount. Preset amount. Okay? The metered dose inhaler delivers the same dose of medication each time it is used. Drugs given via the MDI act very quickly and are commonly prescribed to patients with asthma, emphysema, and other airway diseases. Number 5. I'm getting some B's and 1 D, and then it looked like I got an A. You are managing a 62-year-old who's complaining of crushing chest pains. Her blood pressure is 84/64 millimeters of mercury, and her heart rate is 110 beats per minute. Medical control advises you to assist her in taking her prescribed nitroglycerin. After you receiving this order, you should, according to this question and the answer, it says B, repeat the patient's blood pressure to the physician and confirm the order. But according to New York State, should that blood pressure, you give them nitroglycerin?
No.
No. Excellent. What systolic that should be? 120.
20.
Beautiful. Now, my other question is, this is to do with medical control. Do you need, according to New York State, call medical control to assist with the administration of the nitroglycerin? No, you don't.
Isn't it a standing order or something like that?
It is. That's right. It's understanding orders, okay? Indirect. Remember that? Standing orders, protocols, indirect, okay? It's not like direct control that you're speaking to the medical director at medical control. No. According to this question, that's why you got to be careful. The answer is B. So if you got it incorrect or something, don't worry about it. This question will not be good that we will give you something like this. This will most likely be like a national registry question. Okay? Nitroglycerin is a vasodilator, which you know. Remember, it dilates the blood vessels, especially the coronary arteries, and lowers blood pressure. Therefore, it should not be given to patient with a systolic blood pressure less than 120. Ignore this 100. If you receive an order to give nitroglycerin to a patient with a systolic blood pressure less than 120, you should ensure the physician is aware of the patient's BP, then reconfirm the order. You're not going to get a question like this. If anything, it's going to be above 120, and it's not going to be with medical control, because this is understanding orders. Okay, make sure you know that and remember that. Remember what you're looking for. I think Isaiah and some of you asked ED, the 3 different types of ED medication, up to 72 hours. Okay, that's the average they told you. Okay, the thing here, that's the things you need to know. You have to be careful if there's what was the other one? Some type of head injury, the blood pressure, erectile dysfunction medication. Does that include females? The answer is yes. Okay, just in case they ask you that. Number 6. Now, we didn't talk about activated charcoal much. Things I need you to know for this medication, 2 words, adsorption, AD, and absorption. Okay? Adsorption and absorption. And what's the difference? The absorption is not letting it go to the chemicals and everything through the bloodstream. The adsorption binds and sticks to. So a lot of you are putting D, binds to chemicals in the stomach and delays absorption. That's how they get you on test. Activated charcoal indicated for patients having ingested certain drugs and toxins because of it. These are patients, activated charcoal, that take some kind of overdose on whatever poison they took in. You do not give this, in case they give you a test question on this, with a patient who has ingested acids or alkalis. In other words, think of Drano and bleach. Okay? You don't use this. Petroleum, things like that. Activated charcoal is an adsorbent. That is, it binds to harmful chemicals that have been ingested. The binding affects delayed digestion and absorption of the chemical by the body. That means towards the bloodstream. Make sure you know that, please, in case they ask you a test question on that. Number 7. Okay. With regard to pharmacology, the term action refers to, and the word action here is actually D, expected effect of a drug on the patient's body. That's the word action. As it applies to pharmacology, the term action refers to the effect that a drug is expected to have on a patient's body. Prior to administer any drug, the EMT must be aware of its actions on the body. Number 8. A lot of you are putting your answers here, and a lot of you put A. Which of the following patient is the best candidate for oral glucose? And it's A. Constipation who is showing signs of hypoglycemia, low blood sugar. Oral glucose is given to diabetic patients with suspected or documented hypoglycemia, low blood sugar. It should not be given to unconscious patients or those who are otherwise unable to swallow, because it may be aspirated into the lungs. Epi, there goes that test question you always see. The one that Kenny always gets confused. Epinephrine is given to patients with anaphylactic shock because its effects of, and the correct answer is B. Bronchial dilates and vasoconstricts, doing the opposite what's occurring. The two major complications associated with anaphylactic shock are bronchoconstriction, which impairs air movement in and out of the lungs, and vasodilation, which causes a drop in blood pressure. Epinephrine reverses those processes by causing bronchial dilation and vasoconstriction, thereby improving breathing and increasing the blood pressure, respectively. Number 10. Okay, a lot of you put in C, absorption. Process by which medication to travel through the body tissues until they reach the bloodstream is called, an exact word is C, absorption, not this one. That binds and sticks to. The process by which medications travel through the body tissues until they reach the bloodstream is called absorption. Absorption refers to the binding of one chemical to another. Activated charcoal, for example, delays absorption of the certain chemicals into the bloodstream because it absorbs, binds to them in the stomach. When you give that activated charcoal, don't forget to let them know, besides this tasting nasty and so forth, that their stew is going to come out very black in color and so forth. Okay? Which one would you like to do next? You got neural, you got respiratory, and of course you got 21, which is anaphylaxis. I would leave anaphylaxis for last and do the respiratory and neural first. That's up to you. Talk to me, people. Okay, sounds good. Neural first, everyone. I'm telling you this right now. The reason why the exam was changed from 33 questions to 60 people, okay? That's a good thing. 2 points each, 1 point something, whatever. 60, I like 50. That's me. There was not enough respiratory. So when Christine and myself went over certain things, and I said, yeah, 60 sounds like a good number. That's up to you, Christine. It was changed because your prior exam that had 33 was not sufficient respiratory questions. So are there going to be more respiratory now? Are you following me? So we definitely do neuro now and then respiratory for sure. Okay? Let me get, you said neural. Okay, we definitely, and I'm telling you right now, you're going to see stroke questions, seizure questions. Different levels of responsiveness decrease, some form of altered mental status on this exam. TIAs, status epilepticus, maybe headaches, definitely seizures. Seizures like petit mal seizure, generalized seizure, status epilepticus, febrile seizures. These terms you need to know. When we get down, I'll tell you, make sure you highlight this. Talk about all types of seizures in your introduction, what could cause seizures. Possible causes of altered mental status, intoxication, head injury, hypoxia, stroke, metabolic disturbances. Brain, this always has questions. If I say the brain to you, the computer, I'm talking about your CNS, central nervous system. The central nervous system consists of what two things?
The brainstem and the spinal cord.
That's the brain and the spinal cord, not the brain stem.
Yeah. You're right.
No, you're right on the brain stem, but I want you to keep that to this next question. The brain stem and these other parts here Sorry about that. I'm trying to find my mouse. Brainstem, cerebrum, and cerebellum, okay? These are the major parts of the brain. You need to know each one what it does, okay? So, controls breathing, speech, and all body functions, that's the brain. That's the central nervous system. You're right. Brain and the spinal cord. The three major parts, brainstem, cerebellum, and cerebrum, you need to know each one. They may ask you the cerebrum, largest part. When it comes to here, all this is what you need to know. If I say brainstem, which Maria just mentioned, it controls what? What does that brainstem control?
Breathing, like the vitals.
Breathing, your vitals, the vital functions of life. Blood pressure, systolic and diastolic. Pulse rate, right? Heart rate. And then respiratory rate. Pupils, right? Things like that. Even swallowing. But when you say the vital functions of life, they know exactly what you're talking about. So that's the brainstem. How about the cerebellum? What does that control?
Balance.
Balance, coordination. Okay, cerebellum, cerebalance. Okay, you'll never forget it now. Make sure you know that. And then, last but not least, your cerebrum. Think of everything else. Okay, we just spoke about the brainstem, cerebellum we just spoke about. Look here, blood pressure, breathing, respirations, swallowing, pupil constriction. Logan, is everything okay downstairs? I smell something burning. Okay, make sure. Sorry about that. My grandkids are downstairs. I'm up here. I don't want them burning this house down. What's going on? No, I'm already retired, Papa. You know, I'm waiting till I hit that old age where I can collect in 67. And then my Social Security kicks in. You know, I may wait till 70. God permit I live that long. You know, and collect more than the 100%. You know, I got my pension coming in, and the teaching, I'm okay. Okay, so we got that. We got this. They ask you, right side controls the left. Remember that the opposite. If they ask you the back process a sight, think of the occipital region. The occipital region controls the sight. In case they ask you a test question like that I seen before. Okay. So if you know each controls activities on the opposite side, so if a person has a stroke on the left side of the brain, it's going to affect the right side of the body and vice versa. Okay. The front of the cerebrum controls emotions and thoughts. Okay. And the middle portion controls sensation and movement. Do you need to know that? I never really seen that on tests, only the back portion to do with sight. This test question right here, for magnet, the opening or the base of the skull. That's how they were worded. So they may say the large opening or the base of the skull form a magnet.
The
Make
great
sure you know that.
opening.
Say that again, John.
I remember from the textbook they called it the great opening.
The great opening, they said?
Yes,
Oh, good.
that's how I
Thank you.
remember.
Awesome. Can you put the words on the chat, Kenny or John?
Sure.
Because I heard great or gray. And you know I'm hard of hearing sometimes. Great hole. Got it. Thank you. Test question right here. The brain is sensitive to changes in oxygen and glucose. Mostly, it always needs the oxygen and glucose to the brain, in those brain cells and so forth. Okay, make sure you know that. Always see this as a test question. They ask you any headache questions, you need to know all three. Okay, they'll talk about a tension headache, they'll talk about a migraine, and then they'll talk about sinus. If you think of headaches, Thank you, John. I appreciate it. If they talk about any of these, especially when it comes to tension, I think the pressure of the tension headache, the sinus around the eyes and the nose, and the cheek area here. If to do with migraines, they talk about the patient being very sensitive to noise, sounds, and so forth, okay? So there goes your tension. Make sure you know that. Caused by muscle contractions in the head and neck and are attributed to stress. The pain is usually described as a squeezing or dull or as an ache. That is your tension headaches. Normally, they don't need to call 911 for this, okay? They take some Tylenol, ibuprofen, or whatever, they're good to go. This, very important. Migraines, headaches, my wife has a history of it, my sister and some family members. They are very sensitive to light. This causes change in blood vessels in the base of the brain. The pain is usually described as a pounding, a throbbing, and a pulsating feeling, okay? Often associated with nausea, vomiting, visual problems, warnings, flashing lights maybe, partial vision loss, okay? Know that that's to do with your migraine. So they'll say when you're taking a patient who has migraine headaches to the hospital, should you drive with lights and sirens or should you not drive at all with any lights and sirens? The answer would be no lights and sirens, okay? Because that annoys them even worse, okay? And then in migraines, because they say it can last from several hours to days. I've seen some people they can't even go to work for like 2 days. That's how bad it is. And there goes your sinus. That's the one I tell you about the pressure with the fluid accumulation in the sinus cavities. You need to know that. This patient has nasal congestion, cough, and so forth. May have a fever also. If they ask you about this one, you need to know hemorrhagic stroke, ischemic stroke, and the word meningitis. They're going to give you test questions on that. If I say the word CVA, you know that as a cerebral vascular accident, right? Stroke, you know that's having to do with interruption of blood flow, okay? Result in loss of brain function, okay? And you need to know the two different types. Now, the meningitis, always a test question. I want you to think of fever, okay? Could be mild, but the fever is there. Headache, stiff neck, and possible rash. I'll say it again. Fever, headache, stiff neck, possible rash. Meningitis, affects the meninges. You need to know that in case they ask you that on tests. There you go. And there goes the 2. This is the most common one, is ischemic stroke. Okay? They say about 87% in comparison to 13% of hemorrhagic. This ischemic one you're thinking of, from thrombus or an embolus. Okay? This is your bleed. There you go. 87. There goes results from thrombosis or embolus. Complete paralysis on the affected side. Remember this word with the F in front of it? Fat, arteriosclerosis, fat, lipids, calcium deposits, cholesterol, plaque. That's this word right here. In the blood vessels, often that cause. Why? Because it causes that blockage and so forth. It constricts it. Inflammation there, right? There goes your clot. Right here. And there goes your hemorrhagic stroke. That's the bleed. Any questions on those? Any questions on this, on an aneurysm? You look for the words in aneurysm like the blood vessel shears, cuts on top, and the word you look for is ruptures or bursts. That's your aneurysm. Ruptures or bursts. TIA You may get test questions on this. You need to know that takes care of itself within a few minutes up to 24 hours. TIA. Okay, make sure you know that. Stroke like, but it corrects itself within a few minutes to 24 hours. If they constantly going to have TIAs, is that like a precursor for them having a regular stroke in the future? The answer is yes. Okay, make sure you know that just in case.
It's also known as a baby stroke, right, Nuki? And then
I don't remember the word baby stroke, but I heard it was before, but I always call it the mini stroke.
Okay,
you know?
yeah, right.
Now here, fast. Test questions are always going to be on the Cincinnati stroke scale or the stroke use fast, the mnemonic fast, FAST. If you remember FAST, you know the Cincinnati stroke scale if they ask you a test question. Face, arms, speech, and time. Face, arms, speech, and time. Fast. Think of the Cincinnati stroke scale to evaluate your stroke victim. Face, you have them smile. If they smile like this, big Kool-Aid smile, you're good. If they don't and they smile like this, we have a problem. Okay? So that's the face. It could be drooling also. Then that's the F. The A is the arms. You're going to grab both of their arms, have them place it out with you this way, palms facing up, close their eyes, and then you're going to let the arms go. The arm that drops, that does not stay up, that is the effective side. So you have the arms. The S is the speech. The book states, and we always utilize this for many years, you have them say this: you can't teach an old dog new tricks. They try to say it, you'll hear this. You have a problem. Got that? So, time. The time is very important. They say within that 2 to 3 hour mark. Very important that they should. If they had a legit stroke, they could be taken care of within that 2 to 3 hours. So you must know that that's very important. Yes, Hanson, how you doing?
We may do something for your free time.
Okay, when I get a chance, I'll be downstairs, okay? I love you, Logan. My first grandchild, my oldest.
That's so cute.
You heard him? He made me something, him and his friend Riley. So,
Yeah, that's cute.
Papa has to go downstairs. I'll give you guys a break in a few minutes, okay? Right after
Okay.
this. I'm so sorry. Okay, these are the signs and symptoms that you'll see just highlighted in your book. These are always test questions right here. The word aphasia, dysarthria. Know this, okay? So they may ask you aphasia, difficulty in expressing thoughts or inability to use the right words, expressive aphasia, or difficulty understanding spoken words, receptive aphasia. That's this one right here. They have two of them, okay? One is called expressive aphasia, and the other one's called receptive aphasia. Then the slurred speech itself is this one right here. So know these signs and symptoms. Highlight this in your book, okay? That's where they'll ask you test questions. Besides the other signs and symptoms of confusion, dizziness, severe headaches, and so forth, you need to know, okay? But these words I always see on test questions. Can they give you weakness, combative, restlessness, tongue deviation, and coma? That's a possibility. But if you remember the ones I just told you, you're good. I spoke about the left side affecting the opposite side. Just know the left side hemisphere and the right side hemisphere. Highlight that in your book. This always test questions. Condition that mimic a stroke, you need to know all four of these. So if a patient's having a stroke and it mimics it, it is possible patient who's hypoglycemia, low blood sugar, you think it's a stroke, yet it's low blood sugar, you wind up giving them sugar and they're back to normal. It wasn't a stroke. It was that their sugar was very low. So know that. Post-ictal state, that's the state that they have after the seizure, that they're still in, like, let's say, La La Land. They're not their self yet, okay? And then subdural and epidural bleeding, that's a bleed. This one, subdural, below the dura mater, and that's a bleed above the dura mater. The difference between these two is time. This person here, epidural hematoma, if they have that bleed, that epidural hematoma bleed, it is an arterial bleed. These patients first are unconscious, become conscious, and then in a little bit go back to unconsciousness. Could it happen to a subdural below the dura mater, which is a venous bleed? Because this one is an arterial bleed. This happens over time. So they could be unconscious first, then become conscious, and then maybe days later go to unconsciousness. You need to know this. Any questions on these four? Okay, beautiful. And that's how it looks. It's directly from your book too. Seizures, you need to know the seizures. They're going to talk about that in the book. I want you to make sure you highlight that. This generalized seizure, you need to know that. They're going to have what we call the tonic-clonic state, okay? Abnormal electrical discharge that's happening in the brain. Usually affects both hemispheres, both sides. They go to unconsciousness. They have severe twitching and muscles that last minutes or longer. So they'll be like this, called that clonic-tonic stage, okay? Generalized seizure, make sure you know that. The absent seizure, if they ask you, that's characterized by a brief lapse of consciousness where patient seems to stare and not respond. Almost like they're daydreaming like this, okay? That's the absent seizure. Make sure you know that. Highlight that in your book. Then you have the focal or partial focal seizure, okay? Onset aware seizure, no change in the patient's level of consciousness. Patient may have some form of numbness, weakness, dizziness, visual changes, usually smells and tastes, and may also cause some twitching or brief paralysis. That's your partial focal seizure. Here goes the altered mental status on this also. Abnormal discharge, lip smacking, eye blinking, isolated jerking. Can they have unpleasant smells, visual hallucinations, uncontrollable fears, and so forth? They have this kind of aura, A-U-R-A, okay? A lot of patients who have a history of epilepsy, who are going to have a seizure, are going to tell you ahead of time. You may have a friend says, Maria, don't freak out, but I'm going to have a seizure. You're going to say, stop. What are you talking about? Right? Yeah, I'm going to have a seizure. I know when my seizure is going to come on. Why? I get this aura. What you mean? Well, I have a seizure. You're going to see my whole body go into it. And then right in front of Maria, one of you just looking at you, and next you know, the whole body starts to shake and the eyes close and turn to the side and then lean back and go like this. And poor Maria's like, holy crap, what's going on here? Or any one of you. And they have a seizure right in front of you. And then it stops. And then they come back. And then in a little bit, it goes away and they're back to normal. And then Maria say, damn, you had a seizure right in front of me, scared the crap out of me. You follow me? That can happen to any one of you. Happened to my son. He freaked out. Yeah, he was giving blood. He never gave blood again after that. Yep. He was giving blood with the Red Cross, American Red Cross, and right in front of him, the patient had a seizure. Now, I know all about seizures. He freaked out. Get this, Ivory, get this out of me. He was about to rip it out. He says, no way. The person who was doing the blood taking, the thermometer, said, no, they're only having a seizure. I don't give a, get it off of me. Never gave blood after that I know of.
Nuki, that would do it for me.
Yeah, you see, John's the same way. you see a person having a seizure in front of you when you're giving blood, you're thinking, holy smoke, what the hell they got in that IV or they're doing, right? And he never, John, that I know of, gave blood again that I know of. Just saying. So on oral, know that just in case they ask you. Okay, generalized seizure, I told you what to look at. Okay, highlight that in your book. The absent seizure, also known as the petite mal. Okay, that's the one that looks like they're daydreaming. This always a test question. This is the seizure that goes back to back. So what happens? This seizure starts, they have that clonic tonic, and it looks like it's going to stop, but it has no lucid interval of consciousness. They go right back into the seizure. It's called status epilepticus. Make sure you know that in case they ask you that.
Yeah. Actually, I was kind of confused on like that last slide because it says lasting more than 5 minutes, and then seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes. So is it, but like, what does that mean? Or last longer than 30 minutes?
Okay. You have a seizure lasting more than 5 minutes, likely to progress to status epilepticus. So they're saying that seizure they're having, if it lasts more than these 5 minutes, or those few minutes, which probably going to be after these 5, it could go up to 30 minutes with no lucid interval of consciousness. They're not going to regain consciousness.
Right.
Mostly seizures happen that they have a seizure, and within that 5 minute is done. Okay? But with this, they're saying lasting more than 5 minutes. So let's say 6, 7 minutes, or it could go up to even 30 minutes without them gaining consciousness.
Okay. Makes sense.
Yeah, it makes sense, but sometimes it's all wording.
Yeah, yeah.
Okay, these are things that will cause it. You can look at this in your book and highlight. This is always a test question right here. Febrile seizures to do with fever, especially in children. They use the average age 6 and under. Okay, so they have a body temperature like 104, 105. They're gonna have a seizure called febrile seizures. Test question here, if they ask you, you need to know these main medications. I always see them on tests. Dilantin, phenobarbital, Tegretol, Depakote. 1, 2, 3, 4. I always see on exam. What they love to do to you, they'll throw in a word called Dilaudid with the D. Dilaudid is not a seizure medication. It is a pain medication. Okay? So if you see the word Dilaudid, pain, that's your accept question. For all the following part of seizure medication, accept. So if you know Dilantin, Depakote, Tegretol, phenobarbital, the most of the ones I've seen, and then they throw in the word Dilaudid, you know that's your answer. That is the accept question. So if you can remember all these, awesome. If not, I gave you that site to look up all these medications.
Nuki, can you give those 4 again?
Dilantin, phenobarbital, Tegretol, Depakote. 1, 2, 3, 4.
Thank you.
So number 2, number 3, number 4, number 5. 6 and 7 and number 1 could be on an exam, but I never seen them. But these 4, 2, 3, 4, and 5. Okay.
Thank you,
I have an old story about a doctor who's and I think he still works as the medical director for the fire department. And he was a medic in California. And he wrote this book called Code 1. And this medication that he called, this medication, the patient was saying, I have a history of seizures. And I take this medication. And he said, what medication? He said, that medication called peanut butter balls. And I said, excuse me? And he says, yeah, that medication, peanut butter balls. He said, do you mean phenobarbital? That's what I said, peanut butter balls. Okay? And this is a true story. This is a book called Code 1. Okay? I had him sign it when he became a doctor in Brooklyn. This was in the 90s. This is a story that brings back memories every time I see phenobarbital.
I can't hear anything you're saying. It's like a little muted. Like, I don't know if that's just me, but
Hold on. Who is that? Kenny? Who's that talking?
that is Nick. Yeah, that's better now.
I'm sorry. Maybe I was away from the speaker. Can you hear me better now?
Yeah, that's perfect.
Sorry about that, Nick. This is the post-ictal state. This is the one I tell you after the seizure. Okay. These patients, you'll see they're a little bit lethargic, confused. What they really need, oxygen. Then they'll come back to norm. It takes time, especially after a seizure. So remember, post-ictal state, low blood sugar, which is hypoglycemia, subdural and epidural hematoma mimics a stroke. Be careful with that. That's always a test question. Syncamine, passing out fainting. And then AEIOU tips, anything that will cause an altered mental status. That's in your book. AEIOU tips. Highlight that in your book. Now, if they ask you anything, it's going to be your patient assessment. What you do, you know this already from your scene size up, your primary assessment, your history taken, sample, OPQRST, and all your questions and your body systems, vital signs, everything falls under your secondary and of course your reassessment. If they ask you what stroke assessment you should use, this is the state that I remember. Cincinnati Pre-Hospital Stroke Scale. I call it the Cincinnati Stroke Scale. That's the FAST. FAST. Make sure you know that.
Are we expected to learn all those before, like,
No.
so just the Cincinnati and then the one that Yadiro sent would be smart to learn?
Yep. I see mostly the Cincinnati Stroke Scale, the FAST, always test questions.
Word.
If they tell you to know specific ones, Nick, then you got to go by your senior instructors, which is Irene and Yadiro. I know what I always taught was the FAST, the Cincinnati Stroke Scale, and that's why I always see test questions on. Okay? Can you use the B-FAST? Yes. Can you use the FAST alone? Yes. Okay? I rarely seen Los Angeles or this one right here, or the 3-stroke severity scale lag. I seen this on back of ACRs. The highest number you could get is 15. The lowest number you could get here is 3, and how to break each one down. But otherwise than that, no. But go by what they taught you. I'm just giving you specifics. If they gave you something, what was the other one they gave you, Nick?
Yadiro sent over S-Land. Yeah. Word.
Which one?
Yeah, but since we're like, are they gonna just be testing us on that one or the Yeah, okay.
That's what I remember.
All right, word.
Yes, that's what I remember. Put it on, Kenny, on the chat for me, please. You're a little muffled. Sorry about that, Louis. I'll get a little closer. Is that better? Good. Thank you, Maria. This is the one I see on tests all the time, Glasgow Coma Scale. And this is what I always tell the students to remember. I said, remember the I, the verbal, and motor. And the highest you could get is a 15, and the lowest is a 3. All these and migraines to the strokes and everything is oxygen, oxygen, oxygen. That's what I'm skipping over this. You should be able to know this. If it comes to migraines and they tell you how you treat it, you give them oxygen and you don't, you transport, you don't put on the lights and sirens and things like that. Okay, test questions and then we take a break. Sorry about that. They made me a pepper salad. Not bad. All peppers and some kind of salad dressing. You know me, I want lettuce, tomatoes, onions, carrots, cucumbers, only peppers.
Carcinogens.
Number
Nick,
one,
where are you from? Where are you
me
from?
originally,
Yeah, like,
my nationality,
yeah.
I'm half Puerto Rican and half Filipino. That's
Damn.
where you get the last name,
I got
Nuki.
half right. Yeah.
It's the Spanish in me, CPR, crazy Puerto Rican. And then my Filipino. That's what you used to call me in the street. Hey, CPR. Yo, what's up? And then people used to say, what, they're doing CPR on the patient? I said, no, that's his nickname. They used to call me, if not that, before that was Mighty Mouse. Yeah. Don't ask me why. A little buff, little EMT buff, ready to kill anybody who messes with me. 41-year-old man presented with slow, irregular breathing, hypotension, and dilated pupils. These signs most likely indicate dysfunction of the what? And number one is A, the brainstem. Makes sense. The brainstem is responsible for functions such as breathing, blood pressure, and pupil constriction. Brainstem dysfunction will result in abnormal findings with these functions. Number two. A lot of you are putting D. An acute ischemic stroke is caused by a blocked cerebral artery. I think the dressing they put in there was too much. They're gonna kill me here, guys.
Nuki, be careful.
I know. I think it went down the wrong pipe. I'm trying to chew and talk. Don't do that. That's why the parents, yeah, they tell you don't talk, don't talk when you eating. Yeah, two types of stroke: hemorrhagic and ischemic. A hemorrhagic stroke is caused by the ruptured cerebral artery aneurysm, which causes bleeding within the brain and increases intracranial pressure. An ischemic stroke is caused by a blocked artery, a cerebral artery, either from a clot that grows locally, that is your thrombus. You notice that word? Either from a clot that grows locally, thrombus, or that travels to the brain from another part of the body called an embolus. That's how you know the word thromboembolus. Number three. A 56-year-old man experienced a sudden severe headache and then became unresponsive. He has a history of high blood pressure. The most likely cause of his condition is, and the answer is A, hemorrhagic stroke. Hemorrhagic strokes are typically preceded by a sudden severe headache, signals the rupture of a cerebral artery, after which the patient becomes unresponsive due to the bleeding within the brain. Ischemic strokes and transient ischemic attacks, TIAs, generally do not cause a sudden severe headache, and migraines headaches typically do not cause loss of consciousness. Not bad. Number four. Unlike an ischemic stroke, a transient ischemic attack is characterized by all of the following except, and the correct answer is B, symptoms that persist for longer than 24 hours. That's your except. A, C, and D will be answering the question straight. The accept is B. It takes care of itself within 24 hours. Signs and symptoms of a transient ischemic attack, TIA, are usually identical to those of an acute ischemic stroke. Example, hemiparalysis, slurred speech, confusion, facial droop. Unlike the ischemic stroke, however, the symptoms of a TIA usually resolves within 24 hours. Number 5, remember these, be careful with each one. Not bad. A patient with suspected stroke presents with slurred speech that is difficult for you to understand. This is referred to as, and the answer is D, this one right here, dysarthria. Dysarthria is defined as slurred, poorly articulated speech. It is common in stroke patients. Dysphagia is defined as difficulty speaking. The patient's speech may or may not be slurred. Aphasia is the inability to speak. Dysphagia is defined as difficulty swallowing. Number 6. Okay. A type of seizure that is characterized by severe twitching of all the body muscles and lasts for several minutes or longer is called, and the answer for that is D, generalized seizure. Generalized seizures are characterized by generalized severe twitching of all the body muscles. They often last for several minutes or longer. An absent seizure is characterized by a blank stare. Generalized muscle twitching is absent. That's the one like they look like they're daydreaming. Number 7. The most important reason for promptly transport to a stroke patient to the hospital is, and the correct answer is B, not D. Okay? B. Medication may be given to reverse the stroke, called fibrinolytic medications. I think another word they use is thrombolytics. Clot busting have been shown to reverse the symptoms of a stroke by dissolving the clot that is blocking the cerebral artery. However, for the patients to be eligible for this therapy, it must be initiated within 3 hours after the onset of symptoms. For this reason, prompt transport of the stroke patient is critical. Number 8.
So nervous he didn't even answer the question. So
A lot of you doing it. Which of the following components Cincinnati stroke scale? And it's C. Facial symmetry, speech, arm. F, A, S, and of course, if they had the T, would have been time. The 3 components of the Cincinnati pre-hospital stroke scale are facial symmetry, speech, and arm drift. Both sides of the patient's face should move symmetrically, equally when he or her smiles. he or she, excuse me. This patient's speech should be easily understandable and without slurring. The patient should be able to hold up both arms in front of his or her body with eyes closed and palms up without one arm drifting down to his or her side. Number 9. Some of you will get this number with no problem. Some of you will be like me and you go back to the paper because I don't even remember it sometimes. I know it's the eyes, the verbal response, and the motor. So I always used to go back to my PCR. Okay, this is the number. And that's what I put on my PCR. Maria put A real quick. Kenny put B, maybe A, math is math. And the answer, your patient opens his eyes when you say his name, is making incomprehensible sounds, and withdraws when you pinch the earlobe, his earlobe. What is his GCS score? And the correct answer is A, 9. The Glasgow Coma scale gives a score of 3 to a patient who opens his or her eyes in response to speech. Incoherent sounds has a score of 2, and withdraws to pain has a score of 4. We're added together. This patient GCS is 9. Last but not least, number 10. If a patient brings a severe migraines, how should she be transported? There you go, without lights and sirens, right? C, because it makes it worse. Beautiful. Treatment of migraine headaches is supportive. However, you should always assess the patient for other signs and symptoms that might indicate a more serious condition. Apply high flow oxygen, if tolerated, may help ease the patient's condition. When possible, provide darkened and quiet environment because patients are sensitive to light and sound. Do not use lights and sirens during transport. Okay, how do you want to do this? Do I continue, break, or you talk to me? I know we have to do respiratory, that's for sure.
Can we take a quick break?
We can. You want to take like 5 minutes, 10 minutes real quick, and then just continue straight? Because I know anaphylaxis is going to be quick. Here, you're going to get a lot more respiratory questions.
Okay.
And I definitely want to get this done. So you want to take like 10 minutes? And I mean 10 minutes. There's 8:01, come back like 8:11, 8:12.
That works.
Then there, we go straight?
Yeah, I think that works.
All right.
Thanks.
Yeah, okay. You'll be by you'll be by yourself. All right, see you in a few.
Thank you.
A bunch of beans and pepper salad and onions and you name it with beans. Okay, I had to go downstairs and rinse out all that stuff. God bless those kids. Yeah, excuse me. Listen, we have a lot of fun with both. At least I do. I don't know about that, but let's continue here. Respiratory, very important. What I notice is a lot of conditions. Okay, a lot of croup, hepatitis, asthma, congestive heart failure, COPDers, pneumonia, things like that. Okay, you definitely need to know signs and symptoms. So when we go over this, we say, know this because you may see this again. It is very important for both classes. That's why I told you it went from 33 questions to 60. Okay? Okay, we're in chapter 16, respiratory emergency. Let's go to it. Upper airway, lower airway, you should know already. Upper airway, what it consists of, lower airway, from lung sounds to certain organs and so forth. We'll go over epiglottitis. You're definitely going to see that on the exam. Probably pulmonary edema, asthma, COPD is for sure. Spontaneous pneumothorax, you may. see it. Okay. They may ask you a test question on that. If you see this in comparison to COPDs, remember that this is air in the pleural space. Collapse that lung, one side. This affects both sides. Okay, know the difference. Toxic gases, pertussin, aka pertussin, or whooping cough, you need to know that. Pulmonary embolism, always test questions, okay? And probably industrial exposure or environmental, like carbon monoxide poisoning and so forth. Pneumonia, I always see in test questions. This could be bacterial or viral. Definitely need to know that. Separate that a lot when they talk about fever and so forth. So if they say fever, bacterial, and so forth, you're thinking most likely pneumonia. Okay? If they don't mention things like that to do with fever, and then you get like runny nose and things like that, it could probably be upper respiratory infection. You know this word dyspnea, shortness of breath, or difficulty breathing. They always like to ask you those questions. They ask you anything, what controls your breathing. The ones I always see is active and passive breathing. And they always talk about inhalation and expiration or exhalation, or inspiration and expiration. Make sure you know that. So the active process of breathing. What two gases are being exchanged? Oxygen and carbon dioxide. That's to do under respirations, if you see that word. If they talk about the word ventilations, think about the ambience air here in the room to your lungs. And then all different kind of oxygen devices they utilize to give that oxygen. Remember, if I state I can't breathe, you probably give me oxygen via non-rebreather or nasal cannula. But if you're going to help me with the breathing in the sense of actually do some form of ventilations, that's your pocket face mask, your BVM, your back valve mask, and your CPAP. Know the difference. Upper airway, you know what consists of. That's your upper airway. I always see test questions right here. See this epiglottis? You better know this one. The epiglottis, that's that leaf-like flap that prevents solids or foods going down the wrong pipe, I say. Okay? Make sure it goes down to the esophagus, the food, and not into the trachea. Okay? So make sure you know that. If they ask you how the air goes in, they're always going to talk about the air coming in through here, then going down the trachea, then the right and left main bronchi, okay? Then into the bronchioles, and then to the alveoli. Need to know that in that order. Always test questions, okay? Make sure you know that from superior to inferior or descendant. They can ask you ascending, okay? Inferior to superior. It all depends on the test question and who's giving it to you. Two gas exchange right there we spoke about. How air travels we just spoke about. We spoke about the two processes, which is inspiration and expiration, or inhalation and exhalation. Make sure you know that. We know that the gas takes place exchange at the alveoli. That's how it looks. Brainstem, always a test question. Okay, senses blood carbon dioxide levels increase. Test question here would be brainstem picks it up. There are sensors in your carotid arteries and your aorta that picks up the increase of carbon dioxide in the arterial blood. Okay, so know that word. Carbon dioxide levels are detected at those receptors or sensors in the carotid arteries or the aorta that tells the brainstem for you to breathe normal. So the brainstem, which controls that, tells the pharynx nerve, sends a message to it, which the pharynx nerve sends a message to the diaphragm, and that's how you breathe normal. Okay, make sure you know that. So the test question would be healthy person, normal person, how do they breathe normal? Okay, you must know that. These are problems with oxygen exchange, what could happen. And we're going to get into that now. These are all things that cause dyspnea. I'm telling you right now, test questions I always see: pulmonary edema, pleural effusion, airway obstruction, hyperventilation syndrome. Okay? Definitely industrial or environmental to do with carbon monoxide. And then, of course, drug overdose. That's what they love to give you test questions on. Okay? So make sure you know each one of those. Hay fever is like your common cold. Gas exchange obstructed, damaged alveoli, these are all problems. When you think of this, like damaged alveoli or obstruction of airway passage, let's think of towards the lungs, your bronchioles. This is when you're thinking about COPD is. How you separate them when it comes to test questions? Chronic obstructive pulmonary disease, I want you to think of patients with emphysema and bronchitis, that chronic bronchitis. So emphysema, think of cigarette smokers. Think of all that messing up the alveoli, okay? All that mucus and carcinogens and everything down in the alveoli. If they're destroyed, the surfactant there and everything that helps with the elasticity and contractions of those alveoli to exchange those gases, you're going to wind up with a person with emphysema. If they constantly smoke also or have a history of certain airway problems, lower airway, and you're thinking of chronic bronchitis, that's different. You think of the bronchioles being inflamed, okay, mucus and so forth. So separate those two, and if they ask you test questions on them. If you think of excessive fluid in the pleural space, that pleural space, you're thinking of fluid, or it could be air in the pleural space. If you're thinking of acute pulmonary edema, then you're thinking of fluid inside the lungs. If you're thinking of fluid outside the lungs, you're thinking of pleural infusion. Okay, that's how you separate those two when it comes to test questions. If you're thinking of a collapsed lung, like pneumothorax, you're thinking of air in the pleural space. If it's a hemothorax, that's blood in the pleural space. They collapse that lung. If you think hemopneumo, that's blood and air. All the spontaneous pneumothorax and all the ones I just mentioned, and even open pneumothorax or sunken chest wound could turn into a tension pneumothorax. So you all need to know how to separate all those, okay? These are the signs and symptoms of inadequate breathing. There's a chart you have in your book. You can look at it, highlight the things you always remember. If they use a word like adventitious sounds, breath sounds, that only means abnormal. You need to know how to separate a lot of these meanings here, okay? You should know this one, this one, this one easy. This one, okay? This one when the patient can only speak in a few words. Tripod position, retractions, labored breathing, unequal or inadequate chest expansion, known as also as paradoxal movement, paradoxal respirations, paradoxal motion. Okay, all mean the same, those. Okay, so a lot of these I want you to look at when you get a chance. All cause of dyspnea, what you see out there, upper airway or lower airway infections. Okay, whatever it may be, here's where I want you to look at that they always love to ask you test questions on. Croup. If you hear this, or if they say seal bark cough, okay? That seal bark cough, you hear this. They coughing like that, you're thinking croup automatically. You're thinking of this inflammation swelling, okay, in this area of the pharynx, okay? Stridor sound. Stridor, I want you to think of high-pitched musical, caw or crowing sound. Stridor, okay, upon inspiration. Angioedema could cause that too, swelling. Angioedema, the face and neck, the tongue, and so forth. So you know croup. This bacteria,
Is that like from allergic reaction?
the stridor could be for an allergic reaction. Yes. If you see this, Isaiah, you hear the word stridor, you hear the sound stridor to do with angioedema because of allergic reaction. You better have these other things to make sure you know it's an allergic reaction. What I mean by that is stridor's only one. Now you look at the body and you see urticaria, aka hives, that whole rash on their body. You listen to the lung sounds, lower airway, and they have wheezing. Okay? And then you have low blood pressure, you have anaphylactic shock. You see the difference? Can stridor be to do with a sound to do with croup? The answer is yes. Has nothing to do with anaphylaxis. Stridor is part to do with anaphylaxis if you have all the other signs and symptoms. Got it? Beautiful. Epiglottitis bacterial. So you think of that epiglottis over here, it's swollen and so forth. When you have the inflammation there and so forth, that's a bacterial infection. Okay? You know they're drooling and so forth. You look at them, they wind up having epiglottitis, inflammation there. Nothing goes in their airway or anything like that. So you need to know this epiglottis. Epiglottitis, think of bacterial infection. Okay? That's when you look.
Is that a way to think about it? Like bacterial infections generally cause inflammation, and then viral infections cause something else, or
it's possible, Nick, that a viral infection could also cause an inflammation. Okay. I want you to separate bacterial from viral, because viral, they cannot give you antibiotics. You have to weed that off. It's like a common cold kind of thing. You know, you got to take over the counter medication, drink a lot of fluids and things like that because it's viral. But if it's bacterial, they could say, you know what? There's something bacterial there that we could give you this antibiotic that will work on that bacteria. That's the difference. You see the difference?
Yeah.
That's how you separate them. Can they still be inflammation both on viral, or it could be also bacterial? The answer is yes. That you could get even for pneumonia. Pneumonia would give you more because. Go ahead, Nick. I'm sorry.
Is that like are the antibiotics kind of like that's kind of the splitting point? Like the way to remember between both of them, like viral, you can't be treated with antibiotics.
Yes. Okay. Excellent. Yeah, that's how a lot of people do it, and a lot of doctors and PCPs, their primary care physician will say, I can't give you antibiotics for this because right now I even took a swab of your throat and it doesn't show anything bacterial. This is all viral. All you could do is over-the-counter medications, and I could give you some cough syrup and things like that, decongestion and things like that, but it can't give you antibiotics.
Oh, okay. All right. That makes so much more sense. All right. Thank you.
You're welcome, Nick. So you know this one. That's the easy test question. Think of fever and so forth. Okay. This, you have to separate RSV from bronchiolitis and asthma. The reason why I go over this like this is because you ever going to get patients, or you remember your family members or your little niece and nephew, sisters or brothers with your moms, when they first took that patient to the hospital, they wind up ruling RSV. They have an RSV, right? Respiratory syncytial virus. Common illness in young children, this. Infection in the lungs, breathing passages lead to bronchiolitis or pneumonia. But first is a virus, okay? This is very contagious, this also. Now, when you look at this, they start with this in the ER, RSV. Now, it turns into bronchiolitis. It's still viral illness caused by RSV, but it inflames those bronchioles and so forth, and they wind up giving you maybe albutyl sulfate, okay? So they give that patient albutyl sulfate, thinking it's bronchiolitis. It gets worse, doesn't go away. Now, the next time you come into the ER, the doctor said, at first we thought it was RSV, But then we thought it was bronchiolitis. You know what your child has? Asthma. See the difference? How it progresses?
Yep.
That's how they do it in the ER. Okay, all my years experience, that's what I learned. So I like to teach everybody, know this, if it's RSV first, it is possible to go into bronchiolitis. Is it possible for the bronchiolitis to maybe sometimes in the future turn to asthma? Yes. But if it's something bacterial and they have a fever and everything, they're going to rule out this pneumonia. So, you know the general terms of this. This could be bacterial or this could be viral pneumonia. The worst, of course, is the bacterial. This, they require antibiotics. Okay? That's infection of those lungs. Often the secondary that begins in the upper respiratory tract infection. Always starts like that. Then you have what we call bacterial pneumonia. Okay? Come on quickly, result with high fevers. Make sure you know that. Viral pneumonia presents more gradually and is less severe. So make sure you know that word pneumonia, because that's how they're going to get you when they ask you test questions. Look for the words like fever, bacterial, and so forth. Okay? Pertussin, known as the whooping cough, upon a certain way they breathe. I cannot make that whooping cough, okay? But it's a sound upon inspiration, but it has a whooping sound to it. It's not like the stridor sound or the Seabark cough, excuse me. It's not like that. It's the opposite, okay? That's very contagious. So know the word pertussin, aka whooping cough. You know about influenza, the flu. Highlight that, go over that. Remember that's fever, cough, and sore throat, muscle aches, body aches, headache, fatigue, okay, possible pneumonia or dehydration on this may lead to that, okay? You always get a vaccine for this. I have every vaccine in my body except for smallpox, okay? You must know all these vaccines, okay? I'll have most of them. I always say if it's free, it's for me. Get them. COVID-19, you know. This always test questions. You must know this. They would talk about probably the word they probably would use will be tuberculosis or pulmonary tuberculosis. Okay. Remember, it's bacterial infection. Okay. It's very important that you know that it affects the lungs. Okay. When they cough out, it comes out a productive cough, probably with blood on them also. Okay. You have to know patient will often complain of having a fever, coughing, fatigue, night sweats, weight loss, okay? These patients, if they tested positive with that PPD test they did and that redness and that swelling's there, and they have a history of tuberculosis, then you know what? They have TB. But if it's someone like yourself, let's say you were exposed to this patient and you tested positive for that PPD, that does not mean you have it. That means you've been exposed to it. That's the test question they always like to give. Make sure you know that. In order for them to prove that you have TB, they have to run more tests, more blood tests and x-rays. Okay, so separate that, know about TB if they ask you. Acute pulmonary edema, you need to know that's fluids in the lungs. You need to know left side of the heart cannot remove the blood from the lung as fast as the right side is delivering it also, okay? Fluid builds up in the alveoli and the lung tissues, resulting in a form of acute pulmonary edema, leading to possible congested heart failure. You need to know the signs of APE, congested heart failure, and cardiogenic shock. Okay? Remember, CHF, cardiogenic shock, can develop APE, fluid in the lungs. You need to know that. Separate cardiogenic shock, patient has a heart attack within 24 hours, they wind up possibly going to cardiogenic shock. Remember, cardiogenic shock is a form of, they are prone to pulmonary edema because the left side of the heart is damaged. So all that fluid is going to back up to the left side. It's going to go back to where it came from, to the lungs. When they cough, they're going to cough up a pink frothy sputum and have fluid in the lungs. So LL, left side, lungs. Right side, rest of the body, RR. Right side, rest of the body, you'll see all the edema. The first thing you look for is JVD in the neck. Then you look for ascites in the abdominal cavity, overinflated basketballs, like a lot of fluid there. And then look at the lower extremities for fluid retaining at the feet, the ankles, and the lower legs. Okay? Right there, that's called pedal or dependent edema. You get all that, you got right-sided heart failure, left-sided heart failure, congested heart failure. They love to ask you the test questions between each one. You need to know the signs and symptoms of both. Okay? So think of that. There goes that word, a frothy pink sputum, that pink frothy sputum. There goes the fluid in the lungs. There goes the COPDs. We spoke about this. Tobacco smoke can create chronic bronchitis. Okay, you need to know to separate these. They may give you a test question, wet lungs, dry lungs. If you see the wet lungs, I want you to think of congested heart failure. If you see dry lungs, I want you to think of COPD. Anyone confused what Nuki just said? Wet lungs and dry lungs. No? Okay. We spoke about these two. Any questions on COPDs? Nice. There goes your emphysema. We spoke about this. Loss of dialecticity. Yes.
I'm sorry, just one quick thing. So for the acute pulmonary edema, you said there's the pink frothy sputum, and that's a result from the congestive heart failure, and that we should look for like the left side of the heart is damaged. So we're looking for JVD, you said?
Okay.
And,
okay.
did I get that mixed up?
Yeah. You got it right. If a patient has a heart attack, Deborah, it can lead to two things. The heart attack is going to lead to cardiogenic shock or congested heart failure. The congested heart failure, this is how I want you to separate it. Left side of the heart, lungs. So the lungs, they're going to have probably a productive cough, that they'll have pink frothy sputum, and they'll have fluid in the lungs. Left side of the heart, lungs. Now the right side of the heart, rest of the body. That's where you will see the JVD. You'll know that they have ascites to do with the abdominal cavity, and they have the dependent or the pedal edema in the lower extremities. That's the right side of the heart. You combine that, you got congested heart failure. Got that?
Okay.
Now,
so the JVD and the pedal edema, that's for the right side, and then left
that's right.
side. And
the JVD is only for the right side.
JVD and okay, got it.
Right. JVD.
I had mixed myself up.
JVD, ascites, and pedal or dependent edema, right side.
Got it.
Left side, that productive cough with the pink frothy sputum and the fluid in the lungs. Okay,
Gotcha.
that's the left side. Beautiful.
Thank
and here
you.
it goes. You're welcome. And this is how you will see it here.
Yeah, I was writing it all down and I just mixed myself up.
And this is, I'm going to send you this also on the WhatsApp, so you'll be able to go back to your notes here. Okay,
Gotcha.
but this is
Thanks.
how you see, you're welcome, COPD is. Okay, normal lung, inflamed lung, obstructed lung. And that's what you get. Okay. There goes your wet lungs. Okay, patients with pulmonary edema, wet lung sounds. Patients with COPD, dry lung sounds. Dry lung sounds, there's no fluid there. There could be wheezing. There could be whatever, bronchi and so forth. But they won't be like the wet lungs. The wet lungs, the pulmonary edema, fluid in the lungs, are because cardiogenic shock or CHF. You following me? Good. Excellent. Asthma, constriction or spasms of the bronchioles, inflammation and possible mucus, that's asthma. Okay. So when you have asthma, this is what? That's the normal. That is the narrow one. Look at the mucus, look at the inflammation, look at the constrictions of those airway passages, which is the bronchiole. Okay? You have that, boom, asthma. You're going to hear the sound wheezing upon exhalation. You need to know that. So you're thinking of bronchial spasms, okay, and so forth. What medication we use for asthma patients, asthma attack?
Albuterol?
That's right, albuterol sulfate. Excellent. Oxygen and butyryl sulfate is a drug of choice we always do, right? Make sure you know that. Hay fever causes cold-like symptoms. You know this already. Rarely they give you that. If they do, you know it. Anaphylactic, you must know. That's the next chapter also. But anaphylactic, you need to know what causing the anaphylactic reaction, and anything could cause it. Think of food, plants, medications, and so forth, okay? You need to know that. Remember here, treat with epi. You already know the dosage, you know the oxygen, you know you use antihistamine. They may give you a test question called Benadryl. Benadryl is the brand or trade name for that so-called histamine or antihistamine, excuse me. And the brand or trade name is Benadryl diphenhydramine. Diphenhydramine is the generic. It is in that page, I think Lewis put 508 to 509. Thank you very much, Kenny. Diphenhydramine, okay, which is Benadryl, in case they ask you that. Pneumothorax, we spoke about that. Air in the pleural space, okay, it could be medical or trauma, can cause a spontaneous pneumothorax. That means that collapsed lung. That pneumothorax is the air in the pleural space, collapsed lung. Spontaneous could be medical or trauma. If it's medical, you're thinking of a blep. Kenny, blep, Google, put the meaning for me. That blep is like a defect in that lung tissue area that causes that air in the pleural space and collapses that lung. Yes, thank you. So if it's trauma, it could cause also a spontaneous pneumothorax. Remember, on all these pneumothorax, hemothorax, pneumothorax, hemopneumothorax, spontaneous pneumothorax, tension pneumothorax, the worst of all those pneumothorax. Open pneumothorax from the outside, open a chest injury like a bullet or stabbing to the chest, okay? Also known as a sunken chest wound, can become a tension pneumothorax, which is the worst. You need to know that. Thank you for putting that down, Kenny. Appreciate it. And there it goes. That's how they look. There goes your spontaneous. That's how it looks. So if they ask you, you have it. Pleural infusion, collection of fluid outside the lungs. You need to know that. Inside the lungs, pulmonary edema, acute pulmonary edema. Okay? What's difference between pleural infusion and pulmonary edema? One is inside the lung, one is outside the lung. What's the difference between pulmonary edema and pulmonary embolism? And pulmonary embolisms have different signs and symptoms. Okay? So the embolism most likely began in the lower extremities and traveled up the vein from the inferior vena cava all the way up, went to the right side of the heart, right atrium, down the tricuspid, into the right ventricle, up the right ventricle, of the pulmonary valve into the pulmonary arteries, all the lungs, and got stuck there, obstructed. That is your pulmonary embolism. Separate that from pulmonary edema. You know, obstructive airways, you learn that in CPR. You know, jaw thrusts, and you know, head tilt, chin lift. There goes your embolism, that blood clot. You need to know this. Always a test question. You need to know the signs and symptoms of a pulmonary embolism. Right here. If you know dyspnea, SOB or DB, dyspnea is difficulty breathing or shortness of breath. Do they have tachycardia? Are they breathing fast? Do they have various degrees of hypoxia? Are they cyanotic or cyanosis? Do they have acute chest pains? Do they have hemoptysis, coughing or spitting up blood? And the word here, acute chest pains, they may use the word chest pains or the word pleuritic chest pains. Pleuritic chest pains, okay? To do with the pleurisy. Make sure you know that just in case you see those words. Always a test question, hyperventilation syndrome. You need to know this. Make sure you understand that. Think of the hallmark of this problem. They have numbness and tingling in the hands, fingertips, feet, and toes, okay? That's the hallmark of hyperventilating, and especially hyperventilation syndrome. There you go. Anxiety, dizziness, numbness, and tingling or painful spasms of the hands and feet. You know it also has a panic attack. Carbon monoxide, you know, is odorless, colorless, and so forth. They mostly ask you test questions on here. On your pulse ox, 94 to 99, you look at that number. What can give you a false reading? There's 5 things I went over. What 5 things? Give me the 5 things. Carbon monoxide.
Dark nail polish.
Hypovolemic.
Dark nail polish.
Okay, I got 3 things.
Hypothermia.
Hypothermia. Carbon monoxide poison, I heard.
And the dark nail polish.
And then I heard hypothermia, right? Hypovolemic shock. There's one last one. Starts with the letter A, anemia. Person's anemic. Yes. Those are the 5 things. So know that because they could give you that as a test question. Is there anyone here confused with the words adventitious breath sounds and or abnormal breath sounds means the same? Do we know wheezing, rails, rhonchi, and stridor? You need to know all that. Any ones you're not sure with? So far, so good. All right. You know your sample, you know your DCAP-BTS, trauma, you know your OPQRSTI. You know the monitoring device we spoke about, 94 to 99, pulse oximeter, pulse ox. Look for signs and symptoms of COPD. This is what you may get, okay? Barrel-like chest appearance, use of accessory muscles, abnormal breath sounds, adventitious, tightness in the chest, active or former cigarette smoking. I don't understand people who have cancer. I have a family member right now who's 63 years old. She was diagnosed with cancer in her lungs, still smoking. I don't understand this. Please, someone explain that to me. Why would you do that to yourself? We're going to take the cancer out, but yet you're still smoking. I don't understand. They may ask you positioning. You need to know position. They ask you test questions on positioning like congested heart failure, CHF, or cardiogenic shock. What is the best position to put this patient? On a stretcher. How?
Would it be the position of comfort?
That's one of the answers. If you don't see that, Nick,
You don't see
what
that,
else?
Nick? What else? Left lateral recumbent, I think.
No,
No, that's the bad one. That's the bad one.
Is it?
High power.
High power.
high follow position. Poor Kenny just did this to this patient. He said left lateral recumbent. He just killed him. Yeah. Right. Left lateral recumbent for patients like OD or pregnancy, third trimester, to prevent something. But yes, Nick was right. The position of comfort is the best one. But if you do not see that, you probably see that on the state. But if you see that on a class question or don't see that, look for the follow position. You want them to be upright. You don't want them to be all the way down. No way. You'll kill them. They'll drown in their own fluid. That's what I normally see test questions on, their positions. Okay, every patient here.
Well, wait, I got a question. If we if they're, I don't know. I guess if their position of comfort is causing them more damage, then it's not going to be comfortable. Obviously, yeah. I don't know. Yeah, never mind.
Yeah, but Nick, normally they will not put the position of comfort there also with, let's say, follow position.
Yeah.
It's going to be one or the other. The state will put most likely position of comfort because they know that it's the best position for these patients. But if you don't see position of comfort in the state or class, you're definitely going to see they'll throw in supine, they'll throw in left lateral recumbent, they'll throw in probably I don't know, incline or whatever and then they put full follow or follow position. That would be your best position. You follow me?
Yeah, gotcha.
Good.
Thank you.
You're welcome. All these medical respiratory patients, I'm talking about oxygen. CPAP, MDI, these patients need oxygen, right? But the first drug of choice is oxygen, then how you're going to administer it depending on your patient. If I'm giving a CPAP, what type of patient? CPAP, what type of patient?
Not COPD. Sorry.
Not most likely it would be COPD. It would be what? Fluid in the lungs, APE, CHF patients. You follow me? Those are the type of patients you want to use a CPAP. MDI, if you assist in the administration of this, or the small volume nebulizer, what kind of patients? Asthma. Right? Possible COPD is or wheezing, things like that. Asthma patient, wheezing, right? First drug of choice is always oxygen. Yes.
I had a question regarding COPD. Are we ever going to get a question that says, what kind of oxygen would you give to a COPD patient? I know from the textbook, from reading, they said sometimes it's advised. I mean, you always should give oxygen to a patient, but sometimes, especially in COPD patients, the excessive oxygen would cause them to stop breathing properly because they're getting an overflow of oxygen. So will we get questions like that on the test?
If they give you that, okay? If they're going to do with New York State protocol, it's always going to be 100% oxygen you're going to try to give. The reason why the book states that when you give too much of that so-called 100% oxygen, it could cease their breathing. It is true, but you know how long they have to be on that 100% oxygen? They have to be traveling from New York to Albany 6 hours straight with that on them in order for them to stop that breathing. Your closest hospital for you is 5 to 10 minutes away. If it's me driving, 2 to 3 minutes. Okay? So you follow me? You could give it, but they will not give you a question like that. Don't worry about it. Okay? You always try to, you're welcome. You always try to give at least 100%. Do you ever give 100%? It's rare. How do you give 100%? They have to be intubated. You squeezing that bag. It's hooked up with the tubing, and it's has its reservoir, everything. That's 100% because they're intubated. It's like what's that called? That ventilator machine that's at the hospital. That's how they get 100% because they're intubated and so forth. Otherwise than that, don't even worry about it. MDI, test question. Nebulizer treatment, test question. Better know this. Everything here is oxygen. Oxygen, CPAP, we already spoke about that, the APE patients. Follow protocol. So anytime you know there's acute pulmonary edema involved, you're thinking of 100% oxygen and possible going to provide CPAP according to protocol. Same thing here, oxygen, okay? Asthma, oxygen first, and then the nebulizer treatment that you're going to give. Oxygen is a drug, albuterol sulfate is a drug. Those two drugs combined, boom, probably going to open up those airways real nice. Where they give you on the state that or class that, other than a patient who is asthmatic, can you utilize the EpiPen also? The answer is yes. Why? Because it does the same effect on it as both bronchodilators and vasoconstrictors. Again, oxygen and your epi auto injector, the pen. Here, oxygen again, if you notice. Transport. Oxygen, oxygen, oxygen. Here, you're going to do your CPR stuff or your airway obstruction, maneuvers or Heimlich maneuver. Pulmonary embolism, oxygen again, okay? This is where you need to know the signs and symptoms of pulmonary embolism, which we went over. Hyperventilation, again, oxygen. Do not have patients breathing to a paper bag. Okay, I'm going to say it here, and I know we're being recorded, but Nuki used to do the old technique of putting a non-rebreather on them and then turning the damn machine off, the oxygen off. What do you think it causes them to do? Not stop breathing, stop hyperventilating. This is the reason why. A patient who hyperventilates, right, needs to breathe normal. So what they do, for some reason, they hyperventilate and they do this. The old brown bag technique many, many, many years ago used to be breathing into that bag, puffing, puffing into that bag, right? That technique used to have psychologically an effect also that their carbon dioxide is coming back out. What does the body sense if you have an increase of your arterial blood that it will reverse for you to start breathing normal? Increase of carbon dioxide in the arterial blood. So what I used to do with other EMTs and medics, we gave the non-rebreather, we gave them oxygen, and then we turned it off. And they were breathing in and out their own oxygen and carbon dioxide. It put that sensor to say, guess what? That receptor, I want you to breathe normal. So it stimulates it with the increase of carbon dioxide in the arterial blood. Brainstem went to the pharynx nerve to the diaphragm, and they started breathing normal. Okay? That's why they state here, do not have patient breathe into the paper bag, because that's what we used to do many, many years ago. We don't do that no more. We do the other trick. Okay? When you get it one time in the field or you go to rotations, you get a patient hyperventilating and try, see what happens. See if it still works. They're not going to pass out, trust me. Environmental oxygen. You know this already. Okay. Tracheotomy dysfunctions. We don't do nothing mostly for this. You know, suction to clear the obstruction if needed, provide oxygen. If it's a function, it's messed up, they need that at the hospital. Okay? Anything to do with feeding tubes and everything, we don't take care of, they do that at the hospital. Asthma, oxygen, and, you know, albuterol sulfate. Cystic fibrosis, okay? You notice here is also going to be oxygen, okay? Patient still has oxygen, oxygen, oxygen. Now, questions, and then anaphylaxis. I'm getting a lot of A's. Oxygen and carbon dioxide exchange in the lungs is called respirations. Correct. I'm not even going to bother reading it. We know the answer. Okay. because I want to get to the anaphylaxis and then make sure the notes. What's number 2? Lower airway. It is B. Asthma, right? There you goes, asthma, bronchial spasms. You know that croup epiglottitis, laryngitis is all causes swelling, but that's different. Number 3. Number 3, a lot of you are putting A, tuberculosis, right? Potential drug resistant? Yes. Okay. And they start to be transmitted by coughing, that productive cough, TB. Okay. Remember that. If you test positive for the PPD, you've been exposed to it. Doesn't mean you have it yet.
Nuki, what's C?
This dysphagia?
Yeah, I read it. Thank you.
Bacteria in the membranes, yes. And if I remember correctly, that's like upper airway. Number 4. Accept. All the following are causes of acute dyspnea except something that's acute. Okay? The answer is emphysema. You're right. Emphysema is not acute. Something that is a form of COPD is. There you go. Progressively worsened dyspnea. Asthma, pulmonary embolism, and pneumothorax are all acute conditions. Number 5. A lot of you so far put in A that I can see so far. Bronchial spasms is most often associated with asthma. Okay? If I point to each one here, you'll look at pneumonia, bronchitis, and pneumothorax. All those, inflammation in mucous membranes, pneumonia, one or both lungs, pneumothorax, air in the pleural cavity, pleural space, right? Collapses at lungs. Number 6. Number 6, the correct answer here, a sudden onset of difficulty breathing, sharp chest pain, cyanosis that persists despite supplemental oxygen. The best answer for this one is a pulmonary embolism.
Oh yeah, Yadira was mentioning that if you're giving someone oxygen and their SPO doesn't get better or their oxygenation doesn't improve, and you say what's happening, that's a sign that there's a blockage.
Yeah. So you think of this obstruction, you're thinking of pulmonary embolism. Okay. So look for the signs and symptoms. I guarantee most likely they're going to give this on your exam to do with pulmonary embolism. There goes that pleuritic chest pains I was telling you before. Sharp pleuritic chest pains. Okay. So know that just in case they ask you. Hospital bed, surgeries, traveling long distance, things like that. Number 7. There you go. Albuterol, a beta-2 agonist, is the generic name for what? Hey, that was the easy one, right? Ventolin or Provento, right? You always want to remember this. Albuterol, beta-2, 2 lungs. Alpha, 1, heart, 1. There it goes, ventral and provental. Number 8, remember, this is to do with bacterial. Flap that covers the larynx during swallowing is called epiglottitis. C, right? Makes sense. Number 9. Number 9 is B. 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when lying flat. He is coughing up pink frothy secretion. This patient is most likely experiencing what? And if you look at number 9, you look at B, left-sided heart failure. Remember that pink frothy sputum or that fluid in the lungs, right? If it was right side, what will you look for? Right side, rest of the body. JVD, ascites, pedal or dependent edema, lower extremities, feet, ankles, lower legs. Look at the right-sided heart failure. Look at the peripheral edema in the hands and feet, lower extremities, and so forth. There goes the correct answer. Number 10. Some of you pick these answers so quick, you're such fast readers. Which of the following patient is breathing adequately? When you look at D, it is B. 29-year-old woman with respirations of 20 beats per minute, who is conscious and alert. All these other has some kind of problem, labored, difficulty, or cyanosis. This one should be fast. I just want to make sure you get it on this Zoom video. So when I send it in the upload, you have it. I'm going to pinpoint exactly, more or less. We'll talk about allergic reactions and hypersensitivities, acute airway obstruction, cardiovascular collapse. They may ask you this word. Okay, allergic reaction. They may use the word antigen. This word, test question right here. Caused by the body's immune system, releases chemicals to combat the stimulus, includes histamines and leukotrienes. You need to know these words, okay? These words you need to know. Lungs, bronchial spasm, vasoconstriction, the cause here. In the lungs, you wind up with probably wheezing upon expiration. You need to know that. Make sure you know that to do with the lungs. The heart, you have decreased or low cardiac output here. Okay, the blood pressure is going to start getting low and so forth. Here you have blood vessels, you have widespread vasodilation, leakage, or damaged blood vessels. And then here on the skin, you're going to see edema. That's the swelling, the angioedema, and so forth. Okay, you need to know that. The urticaria, aka hives, and then pruritus, the itching, and so forth. You need to know these signs and symptoms in case they ask you. So, whatever the antigen that came into that body, and that the body's trying to fight that response, you need to know the upper airway, the lower airway, the skin, and the cardiovascular to do with blood pressure to get you to know that they're going into anaphylactic shock and how you treat it. You always give oxygen first and then, of course, the epi auto injector. And you know how. This is your urticaria hives. You need to know this. They're going to give you test questions on this. There goes your angioedema. The reason, lower airway upon expiration. So you may see this, and I've seen this a few times. And then the rest of the swelling on the face and neck, and the hands and the arms and so forth. There goes the stridor. There goes the low blood pressure, nausea, vomiting, abdominal cramps. Now, look at this. If a patient has taken anything, especially foods, may take more than 30 minutes to appear, but they say if they have a true anaphylactic reaction and going into true anaphylactic shock, within 30 minutes, they could die. Okay? From the onset until someone gets there and help them with the EpiPen and so forth. Medication takes about a minute or two to work, the epi, real quick. Okay? Don't forget. So can they be allergic to foods, medications? Yes. Could they be allergic to plants, dander, the environment, and things like this? Yes. There goes the plants, there goes the chemicals, latex, you name it. They give you words like this, insect bites or stings. They have stings from a bee on their arm. How do you take it out? You use a flat surface, a card, right? Do not use a tweezer or forceps to take it out. That will be your test question. Make sure you know that. There goes the stinger, small hollow spine, projecting from the abdomen. There goes the bees. There goes the, I think they're honeybees and wasps and so forth. They leave those stingers in there. You know how to take it out. Army ants, or fire ants, excuse me. Test question right here. You need to know what this is. A wheal. A whitish, firm elevation of the skin that occurs after an insect sting or bite. Know this. Okay, that word, wheal. There goes more signs and symptoms that you'll see. Itching and a wheal and so forth. These are severe anaphylactic patients, what they may experience. You need to know all this. We know this in your patient assessment. This is a nice chart, 21-1. I would look at this, respiratory, cardiovascular, skin, and other findings. Helps you a lot. A lot of this you know already. When you read it, you can say, I remember this, I know this, I understand that. You know sample, you know TLPQ, STI, all that good stuff. Secondary, wheezing, stridor, you know. Swelling, rashes, urticaria. Monitor devices, you know. Reassessment, you know. That's how you take off the stinger, scrape it. Epinephrine, you know this already. You know the dosage. Okay, you know 0.3, 0.15. Other signs and symptoms we went over. Review questions. And then I'll double check everything. This one's pretty fast. What's the answer? Yep. A lot of you putting D. That is correct. What is number 2? Yep. A lot of you put in C. Vasodilation and bronchoconstriction, right? Beautiful. What is number 3? That's a little long one. Read it carefully. A lot of you put in C. Anaphylactic reaction, right? When you look at this, when you read that whole scenario, critical thinking, C. Number 4, what is a wheel? That's an easy one. Yep. A lot of you put in A. Raised, swollen, well-defined area of the skin. Number 5. A lot of you put in B. Scrape the stinger from the skin, which is correct. Number 6. Correct answer for this, from a few of you that I see right now, the answer is C. Provide ventilatory assistance with a back valve mask. You got to remember what you read. Look at the labor, breathing, stridor, and so forth, okay? That's why the answer is C. It's number 7. Upper airway. Yeah, say stridor. That makes sense. There it goes. Number 8. Can all these cause
so-
anaphylaxis?
For all of our, like, I mean, most of our medications that we're going to be administering, like, are we, no matter what, administering oxygen first? Like starting out, like that last question, how it said he had the injector there. Like we would start bagging him before we would administer the epi, even if it was a life threat.
Yes. ABC is always first.
Yeah.
But
Also,
isn't that classified a life threat?
When you look at out in the field, also, if it's considered a life threat, you're going to take care of that first, but you still have to do your ABCs.
Yeah.
Until you're used to it, you're not sure if there's no airway and no breathing there, helping with the epi is not going to help as much.
Or,
Okay. So
it makes total sense. I think it's just the assessment bullshit that's throwing me off, you know, like
yes,
scanning
it's all,
for- yeah.
it's always wording, Nick. That's how they get a lot of us, you know. The first thing you're going to notice you're going to do when you're out in the field is you're still going to do a lot of your ABCs. And then if you notice, if you know this is an anaphylactic reaction going on, of course, you're going to go for your EpiPen.
Yeah.
But if you notice, you figure it's a life threat. But if you notice everything, airway swollen, they have the urticaria, the hives, right? You listen to lungs, you're gonna one of the first things you're gonna do, partner, get the EpiPen, have an anaphylactic reaction. But one of the first things you're gonna do also, while they're still trying to get the EpiPen ready, you're already gonna have oxygen on this patient.
Yeah. Okay.
It's all worded, but yes, I can see where you're going with this.
Yeah.
Like this question, the most common trigger of anaphylaxis, we know it's food, we know it's tea, but all these can cause allergic reaction. So the most common, yeah, but a lot of these, it all depends. This you know already. What's number 9? Yeah, it's B right here. A lot of you know this. What's 10? You notice, hold it in place. It's the wording, how they use it sometimes, right? Because didn't we read the book? And I think Deborah also read it in chapter 21. It said you hold it in place for 3 seconds, but then you rub it for 10. Am I correct, Deborah, to say that, right?
Yeah, it said to hold it for 3 seconds and then rub it for 10.
Now
It's
look at it.
not giving that option.
Yeah, when administering epi by oral injector, the EMT should hold the injector in place for, and the majority you're going to put 10 seconds. I'm telling you this right now because that's what you see, right? So depending how they give you the questions, you'll know more or less if it's a bad question or not. Remember what they taught you and go with that. You can always argue with that with Irene and Yadiro. But the answer was B. Okay, I'm going to stop something here. I'm going to make sure we went over everything.
Are you naked, Kenny?
Bro.
Okay, I could stop recording here, but I just want to make sure we record this, and then you could get as naked as you want to. Okay. We went over all these words. Want to make sure you know it. Actions, indications, contraindications, side effects, untoward effects, you name it. We went over that. The word pharmacology and so forth. Okay. That's on the pharmacology. We went over a lot on that. We went over oral glucose, EpiPen, Narcan, albutyl sulfate, oxygen, aspirin, right? And ipratropium. You're comfortable with that? You're good. You need to know all these medications I just mentioned.
Nuki, I have a question.
Yes.
Well, just to confirm, is Narcan 1 milligram in each nostril?
Yes.
Okay, just want to double check. Thank you.
Well, according to New York State protocol,